So this section of the cardiac that I'm going to be presenting tonight, we're going to take it as far as having coronary artery disease, but we're not going to cover actually having an MI. Let me say that one more time. We're going to take it as far as me living with coronary artery disease, but we're not going to take it to that step of having a heart attack or an MI. That's next semester. So we're going to take you into that acute next semester. We're talking about chronic in this semester. So we'll take it up to that point, and even that chest pain, that's that angina pectoris or angina, whatever you want to call it, we'll take you up to that point, but we're not going to get into actually infarcting the heart. Okay, so that's next semester. So we're building the case, and then when we get to next semester where all the acute things sort of happen, then you'll understand, oh yes, this guy had previous coronary artery disease, et cetera, et cetera. You can read through the class objectives, there's a lot, but really we're going to focus on coronary artery disease. We're going to focus on angina and how to treat that tonight. And then we're going to build the case, and then we're going to look at a heart failure patient. I think we'll finish this handout actually after your exam next week, but we'll go into heart failures and cardiomyopathies next week as well. If I knew which way the clicker goes, there we go. Okay, primary concepts, perfusion and clotting and immunity. Really going back to that, hypertensive patient who has a perfusion issue. If you remember me talking about that concept on Tuesday. This concept here is perfusion to the cardiac muscle. So when we talk about coronary artery disease, those coronary arteries aren't getting the blood flow that they need, and there's where the perfusion may be lacking. Okay, so we'll talk about that. We'll talk about clotting, because sometimes that's the reason why those coronary arteries are occluded, is because platelets kind of clump together and form a little plaque or things like that. So we're going to talk about clotting as well. And then immunity is interrelated. So a couple definitions, and I am telling you right now, I am not going to ask you the definitions of these on a test question. This is background information. Please don't memorize. Arteriosclerosis, thickening or hardening of an arterial wall, often associated with aging. So it wouldn't be uncommon to see a 90-year-old in part of their medical history as arteriosclerosis, often associated with aging. Atherosclerosis is the formation of plaque within the arterial wall. And this is the primary cause of coronary artery disease development. So having those plaques that are built up in those coronary arteries, this is where we start thinking about coronary artery disease. Arteriosclerosis can be anywhere. That's where my blood pressure goes up a little bit. If you remember those ranges that I gave on Tuesday, if I'm older than 60, I have a little bit of a higher blood pressure. So they're just differentiating between those two. Atherosclerosis development, we're looking at, and this is, I'm going to really spend some time on the labs. So I'm going to just tell you right now that the labs are important. So get them in your brain, star them, circle them, whatever you need them to be, whatever needs to work out. No one's going to ask you what percentage does the LDL carry, but I want you to understand LDL, bad cholesterol. Put a frowny face. If you remember me teaching this in 110 in the lab lecture, LDL is the bad guy. So the lower the LDL, the better. The lower the LDL, the better. Okay. So the LDL bad guys, they move the cholesterol from the liver to the tissues. LDL helps sort of transport them to the tissues. Those are the bad guys. Okay. Elevated triglycerides and LDLs are strong predictor of coronary artery disease. Hence why we do the screening of the lipid panel. Screening of the lipid panel. Really important to pay attention to that. And as you get older, your doctor will probably draw it more frequently. And then cholesterol leads to injury and foam cell production and atherosclerosis. So again, another part of that lipid panel that we're going to talk about, that yes, you do need to know the normal levels. So I'm telling you again, you need to know what the normal lipid panels are. Okay. So, excuse me. when we start to assess somebody that we suspect coronary artery disease, we've got to take a look at a few things. First thing we got to do is definitely look at the blood pressure in both arms. And we sort of talked about that in the hypertensive lecture as well. And the beauty of this content is a lot of it is an overlap. A lot of it, you're like, I already remember this or already heard this. A lot of the medications are overlap. So it's very, very helpful, I think. We're going to palpate all the pulses. We're going to assess bilaterally the differences. Does the right hand have a 3+ and the left hand have a 1+? What do they look like? Looking at the 6 Ps. If you remember that from your head to toe assessment, those are important. Do we have nice brisk cap refill? Is the hand cold? Is it warm? Are they having pain? And then we're going to definitely assess labs. So that's what we're going to spend some time on next. But we want to look at those labs to screen for coronary artery disease. So one of the things, like I just said, was the lipid profile, and I just had mine done because of our Be Well within the hospital. So you got to fast 12 to 14 hours, and they'll ask you that. May you come in, have you been fasting? And in the lipid profile is going to be a total cholesterol, LDL, HDL, and triglycerides. Okay, really important that that patient's been fasting. You should start having them be performed at age 20. I don't know if I necessarily did. I know for sure as after I had children, so that was in my 30s, we started assessing them. And then it says repeat every 5 years, more frequently if abnormal, high risk, or look at that age, which is my age bracket. I'm over 40. So I get it yearly. I get mine yearly. With our Be Well Within, I don't even have to pay for it. So it's kind of nice. So the other thing is if they've started treatment on a patient, they really should get repeat levels after about 6 weeks to see if what I started helped that patient. Okay, so if they decide that I have a really high triglycerides and they put me on a medication, I should get repeat levels in 6 weeks, and then I should be getting them sequentially every 4 to 6 months. Okay, because you don't want this to get out of control. So we kind of talked briefly about the LDL. LDL is the bad guy right here. Okay, LDL, bad cholesterol. So the lower, the better. HDL helps remove cholesterol from the bloodstream. The higher, the better. So the higher the HDL, the better. The lower the LDL, the better. And I'll talk about what the ranges are in a minute. So lots of studies show that we have a decrease in coronary events, decrease in lesions, prolonged survival after an MI, getting all that under control. Risk of coronary disease with the cholesterol greater than 250 is 3 to 4 times, 3 to 4 times the risk of somebody with a cholesterol less than 200. So you already know what the desirable for the cholesterol, total cholesterol less than 200. Now, a lot of this is going to seem repetitive. Take a look at those interventions. And if you think back on the hypertensive patient, didn't we talk about the diet and the DASH diet? Didn't we talk about medications that we can add? We talked about complementary alternative therapies, smoking cessation, not cutting back, smoking cessation, and then increasing our physical activity. So as you see, they kind of go hand in hand. It could possibly be, that they're hypertensive and have some coronary artery disease. All of these interventions are going to help that patient who does have high lipid values, because now we're talking about the atherosclerotic disease, will help that patient. Okay, so again, here's where your job as the nurse, so crucial. You're going to do so much teaching with this, so much teaching. I can't say it enough. So there's your DASH diet again, increasing your fruits and veggies and whole grains, low fat dairy. And I had a patient say, oh, there's nothing but whole milk. I said, who even drinks whole milk? And he said, I do every day, like a gallon. I said, oh my God. So we had to really educate him on how much fat is in whole milk. So it's really important to have that conversation with the patients. Non-tropical vegetable oils. So if you think about it, like olive oil, like palm oil and coconut oil are bad choices. palm oil and coconut, because those are tropical oils. Those are bad choices. Increasing the nuts, those are good too. Now, don't eat 2 pounds of nuts, but increasing the nuts. Limit sweets and sugary beverages. Again, that could help the diabetes. Somebody have a question? Nope. Okay. Lean meats. So we're going to limit red meat. That doesn't mean I can't have any, but it doesn't mean I can eat a side of a cow every night for dinner. So it's really important to have that conversation with your patient. Limit the saturated and trans fat. So you're going to teach your patient how to read labels. They need to know this is high in saturated fat, high in trans fat. So really important that you tell them, start reading your labels. And then if there is resistant to the dietary changes as my father was, get a dietary consult because they're experts. I can talk about you need to do the DASH diet or whatever, but really the registered dietitian can really provide a lot of insight for that patient. Here's your DASH diet again. So again, increasing fruits and vegetables and whole grains and really decreasing that meat and those fatty meats and having lean meat, healthy meats, having some seeds and legumes, which I absolutely love, and then fat-free or low-fat dairy. Okay, and limiting doesn't mean that they can't have any oil, but really limiting the amount of fats and oils, so 7 tablespoons of butter on their baked potatoes, probably not a good choice, right? So really thinking about educating our patient. Very important slide. So, and what I'm saying about this is you need to know what is expected. So if it's unexpected, so I'll give you mine because I just had my my Be Well Within. My total cholesterol was 204. What do you guys think of that? 204.
Yay.
No,
Not bad.
not terrible because guess what? The one before was 221. So I came down. I don't know what, I think I must have been eating a lot of hard-boiled eggs or something, but my cholesterol shot up. So I am happy that I'm going in the right direction. It went down to 204 because last year at this time it was 221. My LDL last year was 108 or something like that. What do you guys think of that?
What is it now?
Ah, very good. I like somebody saying, well, what the hell is it now, Lorraine? It's
Right.
94.
Improving.
Thank you.
Right.
There you go. Now you're seeing me trend downward. I'm less than that 100. My doctor's not going to be up my butt now about it because she yelled at me last year about this. Now my HDL, what do you guys want to guess? What do you think it is?
It's less than 40.
Nope. Wrong, Brianna.
63.
Nope.
It's 85.
Wrong.
75.
34.
108. One more time. 108. And one of the cardiologists said, Jesus, you'll never have a heart attack.
Yes.
I don't know why our HDLs, my mom's is high, my sister's is high. I love the fact I was upset about the LDL, but my HDL sort of balances that out. Okay, so my HDL is 108. Kim Pavel and I used to brag about our lab values every year. We used to compare. So I have been trending and I love whoever just said it's improving. I think that's great that you're kind of looking at what direction I was going. Now I want you to guess triglycerides. Now I got to tell you, triglycerides can go up with a high sugar intake or a high alcohol intake. So what do you guys think my triglycerides are?
Less than 150.
Oh, people, come on.
How much alcohol do you drink?
I drink
I was
none.
gonna say you're drinking, I'm sure, something.
Nope.
It's gotta be
What about the
75.
coffee? Is
I'm
the
going to say
coffee black?
120.
You want to say 120? Okay, that's fair. Guess what?
138.
34. 34. 34.
Amazing.
Isn't it? Now, here's what I got to tell you guys. I eat a ton of sugar because I love sugar. I don't drink alcohol. I really do believe it's my family genes. I really do because there should no way be my triglycerides should be that low, but they're 34. I just got them drawn. So I wrote those down just to brag. Okay. So, and I made a point of talking about those because
Dr. Comer.
yes.
I would get that printout and then I'd frame that.
Oh, girl, I get it every year. Every year I'm over 100 with the HDLs. So
That's-
every single year.
That's cause for celebration.
And this is not alcohol, it's coffee. So the reason why I spent some time actually telling you my lab values and talking about it is you really, and I think it was Audra that said, hey, you're improving. And you really do want to really look at the trends of what that patient's doing. I think that's so crucial. You guys didn't get real crazy about my 204. And then when I told you that it was 221, you're like, hey, that's even better. So you can see I'm going in the right direction. I'm not totally corrected, but I'm going in the right direction. Really important that you pay attention and you can evaluate. So you would probably have a conversation with me of how to drop down my LDL a little bit more. And guess how you do that? And I hate it. Exercise. So that's why my LDL is not great, because I hate to exercise. I have a thing against it. I don't know why. So that would probably be the counseling that you would do with me is, hey, Lorraine, your LDL is getting up there towards that 100. Really might need to think about increasing your exercise. So it's very important that you look at those values and understand why they're off and then what you can do to help the patient with that. As far as the total cholesterol, you can tell me to stop eating so many hard-boiled eggs and maybe it'll come down. So really, really important. Now, if we get values that are absolutely abnormal, then we're going to start talking about these anti-lipemic drugs or anti-fat drugs to lower the lipid levels. Now, I know 100% for sure that you guys have given the HMG-CoA reductase inhibitors, or as we call them for short, statins. So we're going to talk about the statins and we're going to talk about the side effects. And I know all these were like some of your meds that you have to look up as well. We're going to talk about each individual section or pharmacologic class, I guess you want to call it, and what unique things we need to pay attention to when they're on these particular meds. So statins are great. This is what I want to say about statins. They get really great results and they'll look at patients. You can see that LDL greater than 190. And my girlfriend was put on a statin and her LDL was not greater than 190. I think it was like 140 or 150, but her physician didn't want to wait. So he started her on that. Patients with diabetes, age 40 to 75 with LDL levels without evidence of cardiovascular disease. And patients, but our LDLs are between 70 and 189, they have a 10-year risk of coronary vascular disease. So it's really important, cardiovascular disease. Really important that we take care of this atherosclerotic cardiovascular disease. Atherosclerotic, not attic, cardiovascular disease. So the statins are a great drug, but lots of side effects. So the beauty of this is I don't know all of these names. I know they end in statins. So then I already go, oh my God, it's a statin. I know what to look for in these patients. So first line treatment for high cholesterol. Probably you guys have seen Zocor and Lipitor. And I think we actually had you guys look up Lipitor. But if you're looking or taking a test and you see the word statin, you should already think HMG-CoA reductase. Anybody know why I care about statins? What's the big problem with statins? Anybody?
Muscle pain.
Terrible, terrible muscle pain. So let's go to that next slide. So that's where that myopathy is, what Francis just talked about. And that's what patients will stop taking this med for. Oh, Nikki Gentile, my dad. He said, no, I didn't like the way it made me feel. And my dad has rheumatoid arthritis in addition to coronary artery disease. So this was really making him even more sore. So he did stop it and we went to a different medication. The worst part of it is rhabdomyolysis. And I don't know if you guys know what that is, but that is a cause of acute kidney injury. And I actually had a lady who ended up coming to the ICU because of a statin and her going into kidney failure. So really important if patient starts complaining of this muscle pain that you pay attention to this and have them call their provider. You don't want them to just stop taking it. You want them to have them call their provider. So one of the things you want to do is tell them to take it at night. So that's where that HS there. I always find it weird when physicians prescribe it during the day. So they can sleep off that muscle pain if there is anything, but tell them to take it at night. Plus, cholesterol recycling occurs when sleeping, so that's the best time to take it to get rid of that cholesterol. Okay. The other thing that you want to put to the side, and I don't see it on here, is put that you need to check liver function tests, LFTs, AST. Oh, it's right there, liver enzymes, AST and an ALT. You really want to trend these in those patients that are starting on a statin because it could elevate to a severe amount that they would need to be off this medication. So make sure that your patient's getting blood work and we're looking at the AST and ALT. Okay, avoid in pregnancy, avoid grapefruit juice again. Who would have thought? Biggest complaint from patients, muscle pain leading to rhabdo. I've only had a couple come in the hospital with rhabdo from a statin. More so it's just this muscle pain that it didn't throw them into kidney failure, but it could. Okay, so make sure that you are monitoring their liver function and kidney function. So your BUN, creatinine, GFR. Okay. Bile sequestrants. Prevents the reabsorption of bile acids from the small intestine. You want to get rid of those. So you might see Questran. You might see, I haven't seen Colistid, but this Welcol, all I want to say about Welcol is they have found it helps diabetics, Welcol, helps diabetics with glycemic control, and it helps bring down the hemoglobin A1C. So if the patient's diabetic, in addition to having high cholesterol, Welcol is a good choice. Welcol is a good choice. Helps, they don't know why it works, so don't ask me that question. They don't know why it works, but it helps bring down the hemoglobin A1C and helps with glucose control in the diabetic patient. So Welcol is a good choice for diabetics. Now, my mother-in-law takes the Questran. Couple things. You've got to mix these in water. So hers is a powder. You mix these in water or a non-carbonated fluid. So don't put it in pop. Water or a non-carbonated fluid, juice, what have you. Okay. So we would definitely need to educate our patient not to mix with anything carbonated. Have that diabetic maybe have their hemoglobin A1C checked, see if that's helping with that. That's really about it. So you can see everybody's constipation, nausea, all that fun stuff. So there is an increase with burping or belching and bloating, increasing dietary fiber or taking a supplement like Metamucil or Glycolax. Increasing fluid may relieve the constipation and bloating. So we may have to add another medication if they're on this particular med. May also cause a mild increase in triglyceride levels. So if this person had normal triglyceride levels and we start to see them trend upward, it's maybe due to this med and we might need to try something different. So really keeping an eye on your lipid panel and making sure that it doesn't inadvertently increase the triglyceride levels as well. Overdose can cause an obstruction, cause a bile secretion not to be absorbed. So it's kind of like cement in their colon. That's why you're increasing the fiber, increasing the fluid. Treatment of overdose includes restoring gut motility, moving things along. Who knows what drug helps with gastric paresis?
Riglin.
Excellent. That's exactly right. Everybody wants to write Reglan for nausea. And I, honest to God, have never given Reglan for nausea in the ICU because people's guts slow down because we're giving them pain medications and they're not moving. We give Reglan to help with gastric motility. So you may see some Reglan coming on the scene for that if somebody has some slowing of gut motility. All drugs, so I have this bolded, must be taken at least 1 hour before or 4 hours after. Okay, so you have to know when to separate medications. Okay, high doses of bile acid sequestrant decrease the absorption of fat soluble. So again, you got to separate that. You wouldn't take your multivitamin at the same time of taking the bile acid sequestrant. Very important that you pay attention to those things. These are teaching points for your patient. They're going to go home. You got to tell them 1 hour before or 4 to 6 hours after other medications. Separate them out. Okay, so my father, remember, he didn't like the statin and he just stopped it, which was not a good thing. And his doctor put him on niacin. Well, that was all fine and dandy until he had the side effect from the niacin and he stopped that. Niacin is a vitamin, right? Vitamin B3. Pretty inexpensive and does a nice job, but a lot of times patients can't tolerate it. Anybody know what side effect?
Flushing.
Maybe.
Yes. So this right there. And that's exactly what my dad had. Oh my God, he drove me nuts. And he said, I'm not taking this anymore. So he had that flushing. And interesting, it increased myopathy with statins too. Like if I was on niacin and a statin, of course, I'd have an increased chance of myopathies there as well. Here's another thing. You got to check your liver function. So you got to get an AST and an ALT. It's just not good enough to just memorize that it can cause liver dysfunction. You as the nurse need to know what to look for that would reflect liver dysfunction. Okay. Pruritus, they're going to get itchy, and then flushing because it causes a histamine release. And those are the pictures of not my father, but of patients who've had niacin who had that flushing. Haven't seen niacin on the scene too much. We really have been going down that statin road. And I don't know if it's just because they've seen better outcomes, but I've seen more statins ordered than anything else in this list of medications that we were talking about. Fibric acid derivatives. This is nice too, because I want you to look right here. I want you to highlight this. Main effect is decrease in triglycerides. And I went to nursing school with a girl whose son, I think he was 12 at the time, had a triglyceride level of 1200. I didn't say 12. I didn't say 100. I said 1200. And she said when they drew his blood, it came out like globules of fat. That's how high his triglyceride levels were. Really, I mean, genetics played a huge role, of course. He's 12 years old. So he was started on meds at at age 12. So you might see Lopid or Tricor because we want to bring down those triglyceride levels as well. Abdominal discomfort, diarrhea, nausea, all the same. Increased risk of gallstones. If you don't have a gallbladder, I guess you don't need to worry about that. Prolonged PT. So we definitely want to look at our coag times. So that's a PT, prolonged PT, prothrombin time. Liver studies again. So I want you to make sure you're looking at the AST and ALT. I can't tell you how many times you'll see subtle changes in the AST and ALT, all related to medication. So make sure that you're really paying attention to what your patient's lab values are doing. You may be the only person that's keeping an eye on it. So make sure that you pay attention to that. Zetia inhibits the absorption of cholesterol, reduced total LDL and triglyceride. And then this is what my dad went on as well, but he stopped taking that too. Often combined with a statin drug, can be used as monotherapy, can be used alone. And then again, watch for muscle pain or weakness. And again, AST, ALT. And of course, you're going to monitor your lipid levels in all your patients who are on any type of medication for your cholesterol. Combinations, you might have a statin combined with something else. You can see all of them are a statin, and then amlodipine right here. This is Norvasc. So that's going to affect the blood pressure. So if I have high cholesterol and high blood pressure, this would be a good choice. I could take one pill to help with my LDL, my triglycerides, and I can help bring down my blood pressure as well. Now, my dad does not have a blood pressure issue, so he's not on a blood pressure medication. He just has coronary artery disease due to his diabetes. Okay, so if they're hypertensive as well, this is a really nice choice because I can get two for the price of one, I guess, if you want to or kill two birds with one stone if you want to look at it that way. Garlic. So about 20 years ago, I was on a huge garlic kick. And when I mean a huge garlic kick, I was eating probably 6 to 8 cloves a day. One, I love the taste of it. And two, I was like, I needed to bring down, I had some platelet issues and some things like that. So that's why I started it. Of course, I woke a sleeping patient in the ICU after I ate my lunch, and she said, "What the hell did you eat?" So you really want to be very careful. And this is what I was talking about with the hypertensive patient. When we start adding herbal supplements, it 100% could interact with our medications that we're taking. And if you look here, if I'm on Coumadin for blood thinning, it can definitely have an interaction. Coumadin is warfarin. And it may enhance bleeding when taken with not NSAIDs. So, if I'm popping NSAIDs for a headache and I'm taking all this garlic in, it certainly can make a big deal, and I could bleed. So really asking that question, because sometimes people don't even think of food as medicinal. So garlic can 100%, like I was going to have surgery and he said, you need to cut the garlic a week before you go to surgery because you can bleed more with increased garlic. Flaxseed, I was on that kick too. Flaxseed's really, really good for bringing down the blood sugar. I was also using it for my autoimmune. I thought it would help with inflammation. So I was hitting the flaxseed and the garlic pretty heavy. About 20 years ago, I've stopped. I actually kind of like the flaxseed. The flaxseed down below in that picture, if you take it this way, you guys, you won't digest it. You'll actually just excrete those seeds the same way that you swallow them. So you have to crush it. I used a coffee grinder to grind up the flaxseed. And then I would put it on my salad or whatever I was eating that day. So those seeds need to be ground, and you don't want to buy it ground. You want to grind it yourself because it can become rancid really quickly. So I was actually taking it for glucose control because I knew my dad was a bad diabetic. And I never had a cholesterol problem, but I really thought it would help me with my platelet issue.
Dr. Colmer, I've seen
Yeah.
people put it like in yogurt or something
Mhm.
so that it's like swells. Would it be digestible at that point, or does it have to be crushed?
It has to be, because if the seed is still intact, unless you soak them enough and it breaks the integrity of it, I guess. But I was always taught, I had my little health food store ladies telling me this. You have to crush that seed open. Now, some people do take the oil. I didn't do the oil. I did the seed.
Hey,
So
thank you.
go ahead.
I just said thank you.
Oh, you're welcome. Yeah. I mean, and I personally liked it. It was a nutty flavor. I put it on my salad. I have put it in yogurt. I've put it everywhere. That was when I was on my kick 20 years ago. So definitely need to slowly increase. If you're going to talk to your patient about this, slowly increase, because it can cause diarrhea. So you want to be very careful, like start small and increase the amounts. Possible interactions, there's your diabetic drug. Remember I said it can help me with my glucose, and then anticoagulant drugs as well. Fatty acids. Cardiology went through this like big deal probably 20 years ago. Everybody was on a fatty acid. I haven't seen it that much anymore. I did take care of one patient this weekend. She's a nurse and she was on fish oil. So that she still was taking fatty acids herself. I don't think anybody prescribed it. She bought it over the counter. Again, they need to tell us, because if you put somebody on an anticoagulant and they've been popping fish oil products at home and we don't know that, we could definitely have an issue. So really paying attention. And 20 years ago, herbal remedies were huge on boards because everybody was taking them. So there are still some questions out there with relating to herbal remedies. Okay, so before beginning any therapy, obtain a thorough health history and medication history. Getting maybe a 24-hour dietary diary from them is helpful, because that would be a great starting point of, okay, I see that all you eat is deep fried fish sticks. Then you can have that springboard point to jump off of to have a talk about how we can change their diet. What kind of exercise level? Are they weight proportional with their height? Do they need to lose weight? What do their vital signs look like? Tobacco can cause vasoconstriction. And if we already have arteries that are clogged and now you're smoking, you're going to make that constriction worse. You can cause cardiac disease with excessive alcohol use as well. And then look for contraindications, and definitely really looking at, are they complaining about muscle ache? Are they not peeing as much because now they're in kidney failure or what have you? Really paying attention to those things. Drugs are great, but they could also cause many, many, many unwanted effects. Contraindication, like especially with the med that my mother-in-law was on, the bile acid sequestrant can cause obstruction. These can elevate your liver enzymes. They can put them in active liver failure. You want to make sure you're looking at AST and ALT. That's your liver function studies. You want to make sure that you are supplementing with a fat soluble vitamin and make sure that it's not taken at the time that you're taking the other medications. And then refer to guidelines regarding administration times. Remember, the statins better administered at bedtime. Annette, who you guys had in OB, used to work for cardiology practice, and she said always gave her patients a statin at bedtime. So, that can kind of help combat some of that muscle weakness if they sleep through it. We already talked about counseling on how to take and you don't just say in your teaching component, I will teach the patient to take their meds properly. I don't know what the heck that means. So when you're writing up your teaching component, you should be really specific. Mr. Jones, you need to take your blah, blah, blah statin, whatever one they're on, at bedtime. It will help you with blah, 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 blah. Really important that you're very, very specific in your teaching. And then powder forms, mixed but not stirred. So you can't shake it. Isn't that a drink? Shaken, not stirred, and never taken dry. So you don't just chug the powder. It has to be mixed with a liquid, non-carbonated liquid. We know that medications should be separated to avoid interference with absorption and to minimize the adverse effects, and to start low and then they'll gradually increase. My dad wasn't having any of that. He just stopped it. So really important, you educate your patient not to just stop the medications, to notify the provider.
Dr. Comer, that shaken, not stirred is from James Bond.
Isn't it a martini or something? I don't drink. I don't know. So
That's where he got it from.
I probably did. And the old James Bond, not the new one. All right. So small doses of aspirin and NSAIDs may be taken 30 minutes before. That can help with that massive flushing. If the patient's able to take a baby aspirin, that's 81 milligrams, or an NSAID, like, 200 milligram of ibuprofen, if it's not contraindicated. Provide teaching, because now this could cause bleeding too. NSAIDs and aspirin increases our risk for bleeding as well. Inform patients is maybe taken several weeks to show effectiveness. Don't be my father. After 2 days, he's done. You got to let the patient know that it may take several weeks for your lab values to come down, things kind of to normalize. Instruct patients to report persistent GI upset, constipation, or an abnormal bleeding. And the yellow discoloration of skin, anybody got a clue what that is maybe related to?
Liver functions.
Yes. And you guys, we just said how many times, look for the AST, the ALT, right? So definitely, oh my God, somebody comes in jaundice, we've waited way too long for this patient to come in. So really, really important that you educate your patient. If you start noticing your eyes are getting a little bit yellow, call the doctor. Monitor for therapeutic effects. So that's where your repeat lab values, cholesterol, triglycerides, the HDL, the LDL. So you know it's effective, hence that would be like a test question is, how do you know that blah, 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 statin is effective? Well, their cholesterol level dropped from 300 down to 200. And you might say to me, well, Lorraine, 200 still abnormal, but it's going in the right direction. So it's doing what it needs to be doing. We may just need a little bit more med. But that's how you monitor for therapeutic effects. That's how you evaluate. That's how you answer those evaluation questions. Okay, smoking. Can't say it enough. I don't know how many times I got to say it. Absolutely no smoking. Number one modifiable risk factor. It causes vasoconstriction in small vessels. So if I've already occluded a vessel full of plaques and such, and now I'm smoking, I've made that vessel even smaller. I'm setting myself up for an MI. Increased release of catecholamine. So we talked about that, epinephrine and norepinephrine. Makes the heart rate go up, makes the heart work more, the blood pressure goes up. Definitely makes things worse for the heart. And then risk of death proportional to the amount of tobacco use. Stopping can decrease by 80% in 1 year. That just blows me away. And I'm not going to ask that test question because that's a stupid question to ask. That's just a fun to know fact. But you can see where you can use that as a powerful statement with the patients when you're teaching them about not smoking anymore. You can say, hey, listen, it can cut your chances of having coronary artery disease by 80%. That may have an impact on the patient. So you see why I've shared that with you. All right. Physical activity. And again, this is my most hated. This is where you'd have to really work hard with me. You'd have to really have me buy into why I need to exercise. Good God, 4 times a week seems like a lot. Now I know there's probably people out there that exercise every day and I applaud you. I prefer to sit on the couch and watch murder mysteries and not move. So really important. You're going to have to convince me what would be the best way to get me to exercise, or you're going to have to make it a competition because I'm very competitive. So that might be a way to get me to exercise. Adjust for age, ability, and inactivity. And honest to God, I tried one of these swimming classes and I kept floating away from the group because I couldn't maintain myself on the floaty. And they were all looking at me like, you're a complete idiot. And they were like twice my age. So I skipped the water class. I'm done with the water class. So really looking at what can the person do, what age group, what kind of activity. I mean, I'll never run a marathon, but I could probably walk around the block, maybe. I can't guarantee that I'm really going to do that though, but this would be my hard sell. You're going to have to really convince me on how I should exercise. All right, why don't we, you guys want to take a 5-10 minute break? How about I stop and answer any questions up until this point?
The only one I had was you said it's always better to have the HDL be higher, correct?
Correct. Yep.
And
So-
the LDL lower.
Yep. So
Okay.
think high. So high HDL, high HDL, low LDL. I put the H and the H and the LDL together. Do you know what I mean? So the lower
Yeah.
the better, because that's the bad guy. So we don't want a lot of the bad guy, but we want a ton of the good guy. That's why I share my values with you, because mine are awesome. And no, I mean, really, that's the way I remember them, is I know that I have the really good guy that's up. What
Okay.
other questions?
Lorraine, on this slide with the values for LDL, it should be less than 100, but then there's also less than 70. Do you want
So,
this?
go back. What slide is it on?
It's under the DASH diet. It's the goals of hyperlipidemia therapy, the levels, like the values.
Yes, so that's the high risk patient. So let's talk about my dad. My dad's high risk. And why is my dad high risk? He has already had previous coronary episodes. He is a terrible diabetic. So because they're at a higher risk, that's why the less than 70. They're even making them to a lower standard. Does that make sense?
Yes, that does. Thank
But
you.
all these underlying problems that could just complicate things. So we want to keep them even a tighter control.
Okay, thank you so much.
You're welcome. Any other questions?
Yes, you said about taking statins at night because of the leg pain,
Yes,
but do they
but
get
not leg pain, muscle pain. Don't just stay with leg pain, muscle pain.
okay, muscle pain?
Yep.
So could it be possible that if they take it at nighttime, they
No version of the article with the correct data.
Wait a minute,
from other
I'm hearing a
articles.
couple people
To
talk.
do is
He was the one going to those ranches. He was the first to see people were dying.
Can everybody else mute? Can everybody else mute? Okay, go ahead, Dawn.
okay, so if they were to have bad muscle pain, could it possibly like wake them in their sleep and then they
Oh,
would-
I wouldn't doubt it. I mean, I honestly, if it's that severe, Dawn, I would say that we need to have a conversation with the provider. You know, now it's waking me up in the middle of the night and all this stuff. So my dad, you know, he's not tolerant of many things. I don't know how bad his was. He goes, I just stopped taking it. And I'm like, no, that's not what one does. So if it's waking the patient up, it's definitely a conversation they need to have with their provider. Definitely.
Okay, thanks.
You're welcome. Any other questions?
Yeah, I do have one for you. It's Bree. Do you, for the lab values, do you want us just to know the normals then, not like the increased risk patients normals, or which?
Probably both, Bree,
Okay.
because let me ask you this. So you're coming in my room
Mhm,
and I'm a bad diabetic. What are you
okay.
gonna tell me? What are you gonna share with me?
How you need to cut back and why?
And what should my value be then, my LDL?
Less than 70. then-
Right? Because I'm gonna be like, girl, I'm 94, and you're gonna be like, too
Okay.
bad. You're a bad diabetic.
I
So do you see what I'm saying? So like, it's good to know that there's a different range for people who are at risk. It really is good to know. And I think that's the only one that's sort of, that LDL is just a bad guy. You know what I mean? The lower, the better you can get it. I mean, I used to be in the 40s with the LDL,
Mhm.
and then I don't know, I got even more lazy than I used to be. But really keeping it as low as possible is the best thing to do.
And then you said something about the triglycerides could go either way. I don't know if that was just like in your by your levels, like it could be either high or low, or what were you saying about the triglycerides?
Either way,
Yeah, I
you
don't know.
want them less than 150.
Okay,
I don't remember saying either way. I don't know what I'm
so
thinking.
they just need to be less than 150 then.
Yes, and again, the lower the better, especially if I'm a high risk person.
Okay,
For instance, if I'm up 100 pounds and I need to lose that 100 pounds, you definitely want to bump that down because I'm a higher risk patient than somebody that's not 100 pounds overweight. Do you see what I'm saying? So you got to really look at the situation. The guidelines are cholesterol less than 200, LDL less than 100, the
Okay.
HDL greater than 40, women, men 35, I think.
okay.
However, you really, when you are on clinical, and NCLEX won't ask you specific patients, but on clinical, you know, if you see a bad diabetic, you got to be like, whoa, we got to get this under control.
Okay.
Does that help?
Yeah, it does. No, I just wanted to make sure that I had the levels like properly
Mhm.
right. So HDL you want at a good level, higher the better. LDL triglycerides you want lower the better. Okay.
You got that right.
All right. Thank you.
Got that right. Anybody else? All right, so what is it? It is 6:23. Let's take a break till 6:30. So you got 7 minutes to do what you need to do. I'm going to pause our recording. Okay, we're good. So acute coronary syndrome, all I want to say about that is we sort of changed our language, and we used to call it like MI or all this stuff. And now we kind of have this sort of umbrella term. So acute coronary syndrome. So in this, we're going to talk about the coronary artery disease. We're going to talk about angina. And we're going to talk about the medications to treat that. So a lot of them will overlap with what we talked about. So this will hopefully be some review on your hypertensive meds as we go along here. Perfusion again and comfort, because now we're going to start talking about some chest pain. Now we're going to talk about some chest pain. So coronary artery disease includes chronic stable angina. So when we say chronic stable angina, we're really saying, I kind of know when my chest pain occurs, if I shovel the driveway, if I, so I know when it's going to happen, so I can pre-medicate before that. And then acute coronary syndrome is sort of a general term. It could be ischemia to the heart, which is that definition right below, or infarction, which is death. So you definitely don't want to get to the point of a myocardial infarction because that's death of the cardiac tissue. Where ischemia is just a lack of blood flow, and if we could reperfuse that area, it won't cause permanent damage. So you want to catch it when they're ischemic, not when they have infarcted. Infarcted's too late. It's already dead, done. Okay. Oh. All right, so these are going to sound a lot familiar, just like our hypertensive patient. So CAD increases with age. And you can see women are a little bit more protected because of hormonal things until they go through menopause. So you can see that age is a little bit higher than the men. Higher incidence in African Americans. A lot of times there's a lot of diabetes and hypertension with African American patients. So that could be the reason why they're an increased risk factor. Heredity, you can't pick that. So you definitely want to know what your family history is. Men develop earlier than women. So those are the non-modifiable, which is the same thing we talked about with hypertension. You know, you can't change your race. You can't change your age. You can lie about it. You can't change your gender, what you're born with. I mean, you can physically change the outward look of your gender, but you can't change that you were born with male versus female. So those are the things we can't modify. Things that we can, remember, stop smoking, lose weight. See, it's getting a little repetitive. I hope you guys are picking up on that. Hypertension and diabetes, two big culprits. High cholesterol levels, hyperlipidemia, metabolic syndrome, where that excess weight's around your belly. So you want to make sure that you kind of address those when you're talking to a patient. And I remember before I lost my weight, that was the first thing that my doctor talked to me about when I went to her was, oh, how are you going to lose this weight? How are you going to lose this weight? She would not let that go. So thank God I lost the weight, and then she can let that go now. But she's moved on to other things of me not being physically active. So really important that you have those conversations with your patients. All right, so new culprits out on the scene. So this homocysteine, it's a level that we can draw. And they're looking at that of if it is elevated, they have a 70% chance increase of getting coronary artery disease. So if we're suspecting somebody who might have coronary disease, we would look at those homocysteine levels. I have not seen it that oftenly drawn. I think I've seen it once. And again, I didn't work in cardiac, I work in renal. So it could just be the service that I work for. Bacteria, some infections inflame arteries. When we have a bacterial infection, and we'll talk about this next semester in critical care, when we talk about that SIRS, or that systemic inflammatory response syndrome, that causes this massive inflammatory response. COVID, which is what everybody's been talking about, we have this massive inflammatory response, and why we're having all these complications with COVID is that the body has this massive inflammatory response. So definitely taking a look at bacteria being a cause. C-reactive protein, you probably remember from rheumatoid arthritis or any kind of inflammatory process. So a lot of times they're drawing these C-reactive proteins in people who we suspect that might be having an MI. Do they have this high elevated C-reactive protein that's causing this inflammation within the vessels, which then is causing the MI? So we're starting to draw those C-reactive proteins, not specific to the heart though. The C-reactive protein can be elevated, I don't know, lupus, any kind of autoimmune disorder, anywhere that there's inflammation about a massive infection. So it's not specific to coronary disease. It may be just another screening tool. And then they're saying HPV can lead to inflammatory response in blood. That's why they're recommending people being treated with a Gardasil and prevent oral and cervical cancers and heart disease. Vitamin D deficiency. Now I have to tell you, the practice that I work with, which is renal, this is every patient we get a vitamin D level on. And we're approaching it from bone disease and kidney dysfunction. But they're now seeing, and I know you've probably heard in the news with COVID, they were telling everybody to take vitamin D to
Hey,
help.
Dr. Colmer, can you
Yes.
let Elise back in? I'm so sorry. I didn't mean to
Oh, I
interrupt.
did. She should be in.
Yeah, I'm sorry. I'm in now.
Oh, for God's sakes, Elise.
Stop. I can't. Sorry.
I forget where I'm at. Okay, you got to go this way, Lorraine. Hang on, nobody panic.
Vitamin D.
Thank you. Whoever just said that. Thank you. Okay, so if they're deficient, and every patient I drew a vitamin D on this past weekend was deficient. We live in an area where we don't get any sun. So they're definitely really recommending. And so my husband and I both, when we started taking care of COVID patients last year, we just bumped up our vitamin D intake to 2,000 a day. So we were trying to not get sick with COVID because we were working in it day to day. But it also helps with that inflammatory response. So they really, really do recommend that you check vitamin D deficiency, which everybody in this area is deficient, and treating it with a supplement of 1,000 units a day. I bumped it up to 2,000 myself. Okay, so development and progression of CAD. So we talked about that atherosclerosis and seeing, as years go by, and I'm certain if somebody went in and took a look at my coronary arteries, I'm certain that I have plaque buildup. I mean, I'm 55 years old. So I'm certain that we all have some sort of. We don't want to get to the point where at the end where the plaque ruptures, because then you can throw clots and you can infarct your brain or you can infarct the heart. So you really, really want to go way back to where that lipid retention is and take care of things right away and not get to the point where that vessel's occluded. Now, I don't know if you've ever read anybody's heart cath reports, when they go to heart cath. They really don't do anything if the blockage is less than 70%. They go in and they say, all right, Lorraine, you got 50% blockage and blah, blah, blah. And they don't really do anything. And hopefully if you're old enough, you get collateral circulation. So that collateral vessels, that as we age, we tend to develop some collateral circulation to help that area around the heart get perfused. It's the young person who doesn't have the opportunity to develop these collateral vessels to help nourish the heart that die of a heart attack and just go over, because they don't have that beautiful collateral circulation to help fill in where the other artery might be not properly functioning. So very important to really keep that blockage down, really try to do that preventative before we have to be interventative. I don't even know if that's a word, to intervene. So really important that we try to push home the activity, the diet, the weight loss, the non-smoking, getting the blood pressure under control before we get into having a lesion. I don't know if you know this, but it has to be 99% or less for them to actually intervene. If a vessel is 100% blocked, they cannot go in and balloon it, or whatever language you want to use, plasty. It has to have some avenue for them to get that catheter in. So if a vessel is 100% blocked, there's nothing you could do for it. You're going to have bypass. All right, pressure increasing within the lesion can lead to rupture of the lesion. If we have a plaque rupture, and this is where that platelet aggregation occurs, and all that fancy word means is they clump together, and those clump together and cause a blockage. So if the plaque ruptures, it activates the platelets, and the platelets go nuts, and they decide to go over to that lesion, and now we've got this area where these aggregated or clumped platelets block off that vessel. So we don't want platelet aggregation to occur. And we give medications once we've intervened to prevent from platelets building up in that vessel as well. Okay. So risk factors accelerate atherogenesis, which decreases myocardial oxygen supply. Always remember, when we're talking about the heart, it's supply and demand, just like if you're a business person. You know, increase supply, we're going to increase the demand, right? Or increase demand, we increase the supply. So if you are going to decrease myocardial oxygen supply, that means I'm not getting enough oxygen to the heart. Now I'm becoming ischemic. I'm not getting enough oxygen to the heart. I'm becoming ischemic and hypoxic. And then that just travels down a terrible, terrible, terrible road. So you want to make sure that you're constantly supplying oxygen to that heart. Okay. Risk factors that increase demand. So if you, I'm going out to shovel the driveway. I don't exercise. Do you think my heart can handle really lifting that heavy snow? And then you hear why somebody maybe had a heart attack while shoveling the driveway, because they're not used to such a physical activity that they've increased the demand. They don't have enough oxygen supply. So again, it's a supply and demand thing. So there's your risk factors that increase the oxygen myocardial demand. I decide to go out and run a marathon today. I will probably drop dead from it, right? Because I'm not trained, I don't know what I'm doing, and I won't have enough oxygen, okay? If you have enough oxygen to match the demand, there's no problem. My son's a marathon runner. He can run 10, 12 miles. He's not hypoxic. He's able to meet that supply and demand. I, on the other hand, will not be able to meet that. So it's really important that if you get it, if you have enough oxygen supply to meet the demand, everybody's happy. Everybody's happy. It's when the supply is greater than demand, aerobic metabolism occurs. Okay, now, oh shoot, it's right below. I was going to ask you, what happens with the aerobic metabolism? I try to breathe deep and take in oxygen, so like aerobic exercise. But when demand is greater than supply, anaerobic. So anaerobic means without oxygen. So do you ever exercise so much that you got a terrible stitch in your side and you're like, oh my God, that really hurts? You're probably producing lactic acid because you're not breathing appropriately while you're exercising. So it's really important to not transition to anaerobic metabolism, because then we produce lactic acid and the patient becomes lactic acidosis. And then they become metabolically acidotic and things just go south from there. So myocardial oxygen demand increases, causing an increase in heart rate, heart size, and resistance to ejection. So high blood pressure. That's why the heart has to work so hard, or if I have massive vasoconstriction in my vessels, which would ultimately result in high blood pressure as well. This is where, when you think of resistance to ejection, think of that systemic vascular resistance I talked about on Tuesday. Amount of resistance that heart has to work against. It has to work twice as hard to get that blood out. It's too hard. It's too hard. Okay. Coronary artery endothelium allows for unrestricted blood flow to the myocardium. Irritants that can disrupt it: cholesterol, hypertension, smoking causes vasoconstriction. Blood sugar, if an uncontrolled blood sugar, can change the vessel. It can damage the vessels. And then pathogens such as bacterial infections, viral infections like COVID. Then disruption of that endothelium leads to development of an atheroma, little tumor, fatty tumor, and plaque. And then there's where you get the blockage in the vessel. Some general terms. Stable angina, I already talked about this. I can predict. Oh, I'm going to walk up a flight of steps and get chest pain. And then I sit down and it's relieved by rest. Or I take my nitroglycerin underneath the tongue, sublingual. So I know when it's going to happen, and it occurs on exertion. So I'm doing something, I'm physically lifting boxes, and I say, wait a minute, I need to take a break. I rest, or I take a nitroglycerin tab, and it resolves. That's stable angina. Unstable, I might be just sitting in a chair and doing nothing and get chest pain. And it may not be relieved with rest or nitroglycerin. This needs to be intervened. This is the patient that if they're sitting there minding their own business and they get chest pain, they need to come for medical intervention. Okay, that's unstable. Can't predict it. Minding my own business, not shoveling snow, not running a marathon, just minding my own business. Intractable or refractory angina, severe pain. And I've had patients infarct right in front of me and say, you know, it's a 10 out of 10 and they're nauseated and somebody's sitting on their chest and it's terrible, terrible pain. No matter what I give them, morphine, nitro, still with chest pain. Variant or Prince metal angina at rest with reversible ST segment elevation. So I think Debbie taught you guys how to read the PR, the QRS, the ST segment. So when we look at that 12 lead EKG, that ST segment elevates off of the baseline, but it can reverse and come back down. So there's no chronic like infarct like changes to the EKG. So it can be reversible. That's a good thing. You want to catch this and get it taken care of. And I can have a spasm in my coronary artery, and there's medications that we can put the patient on to help keep those coronary arteries open instead of spasming. Silent ischemia. This would be my father. My father's diabetic, and a lot of times the diabetic will not have your characteristic chest pain with an MI. He came in, they did an EKG, and they're like, oh, you had a heart attack. Has absolutely no idea when he had the heart attack. Had absolutely no pain because the diabetes has changed the receptors and you don't feel the pain like somebody who's not diabetic. Okay, so very, very important. He had signs and symptoms of like heart failure, edema, shortness of breath, those kind of things that brought him in. Had absolutely no idea that he had a heart attack. Okay. Patient has known threshold for pain, so they kind of know. These patients have lived with it and they know they need to sit down, they need to rest. Occurs in a familiar pattern, tends to be stable for months at a time, causes slight alteration in patient's activity, relieved by, circle that star, that nitroglycerin or rest. One of the things that patients, if they know that this activity, maybe they like to go on a bike ride with their wife at night, and they know that it causes them chest pain, they'll take nitroglycerin as a prophylactic. So they don't have chest pain yet, but they know that they're going to increase the demand, that they want to dilate those coronary arteries so that the blood flow maintains to those coronary arteries during that activity. So patients who are well aware of what their angina is, they may take nitroglycerin prophylactically. Increased physical, I already talked about this. This is why shoveling, and that's why you hire somebody to do, like a 12-year-old to do your driveway. Vasoconstriction, eating a heavy meal. And I've seen that a lot. I actually had somebody come in on Thanksgiving, big meal. And because we have this huge meal, it's actually like will divert the blood to the stomach to try to digest that meal, and it'll take it away from the heart and they'll have a heart attack. So again, maybe pacing themselves, not eating one big meal, like a big meal a day, like small frequent meals during the day. And then another stress or emotion provoking situations. I'll never forget, she was 58 and she was in town. She was from Florida for the death of her son. And she was so emotionally overwrought that she actually had an MI from the stress. And she had no prior history. She had no high cholesterol levels. It was all due to the stress of the death of her son. And that's, they call it broken heart syndrome, actually, is what they called it. And she had an MI just from the stress. So really having conversations with the patients of, you know, don't go out in the cold, have somebody else shovel your driveway, maybe pace your meals. You know, what are some stress reducing techniques you could do to prevent you from having that, because some people will just get chest pain every time they're stressed. All right, so what did the patients describe it as? A lot of times I've had patients say it's like an elephant sitting on their chest. And they'll say it's not pain, it's a heaviness. Some have reported it as pain. Everybody's individual, but I've had a lot of times, more often than not, that it feels like an elephant is sitting on their chest. Sometimes twisting or gripping kind of feeling. A lot of times retrosternal, so behind the sternum, and it can radiate to the neck, jaw, shoulders, or back, and frequently down that left arm. Okay, anxiety could be, one, I'm anxious about it, and now I'm making myself a little bit hypoxic because I'm hyperventilating, could make that pain even worse. The pain of typical angina subsides with rest, or NTG is nitroglycerin. Angina does not cause permanent damage to the heart. I'll say that one more time. Angina does not cause permanent damage to the heart. Infarction does. When something is infarcted, it is dead. So that's when we say myocardial infarction. Unstable angina is characterized by increase in frequency and severity and not relieved. This is the patient that needs to come into the hospital and get medical intervention, whether it's a heart cath, medications, or whatever it is, but they need to come into the hospital. If it's not relieved by rest and nitroglycerin, they got to go. Now I have to tell you, and I always tell the story because I'm shocked that this actually happened, or maybe I'm not shocked. A lady was in from out of town. I forget where she lived. I think Indiana. She was 47. And she went to the hospital and said she just didn't feel well. And she's a nurse. And she told them, I don't know, I just don't feel right and everything. So they give her a paper for anxiety. Okay. Like she didn't describe chest tightness, any of this, down the neck, no, blah. Hand her a paper and say, you need to go see a psychologist. I think you're anxious. So this was at another hospital. She gets in her car and drives down Belmont Avenue, and cardiac arrest in the car with her husband. And she ended up in 4406. So you never forget room numbers, in the ICU. And I remember, and this is when we had paper charts, I remember seeing the paper that they gave her that talked about anxiety. She had a massive MI. She ended up becoming, she was brain dead because she was so hypoxic and she was down, and she died 47 years old. Never complained of chest pain, just kept saying, I don't feel right. Something isn't right. And no one thought to get an EKG on her or take a look at that. She died. And they were treating her for anxiety. So it's really important that you educate. Women especially don't have those characteristic chest pain like men do. Sometimes they just might vomit and they're like, I just feel like I have an upset stomach. It could be really, really different. So you've got to do a little bit more digging with women, I think. Or even a man who comes in uncharacteristic, they might just say, I feel like I have indigestion. That's a common thing that patients will say. I think I have indigestion, and they have no history of GERD or anything like that. Again, getting a 12-lead EKG and really taking a look and preventing what happened to this young lady. So you remember PQRST. So think about that. If there is pain, where is the pain? What brought it on? Oh, I was shoveling the driveway. What does it feel like? An elephant sitting on my chest. Does it radiate up my jaw, down my left arm? What helps the pain go away? Nothing. I took 3 nitro and it's still there. Severity, 0 to 10, of course. And symptoms, what other symptoms? I had a lady that was in church who sat across the other side of the church, and I saw her sort of slump over, and I was like, my husband and I like, do we go over there? What do we do? And here she vomited and was a little like out of it, and couldn't really tell me if she was having pain. Well, she had an MI right there in the middle of church. And we got her to the hospital, and she did okay, but she didn't complain of chest pain to her husband at all. She just sort of went out, vomited, went down on her side. So really important that you get all of the information that you can to understand what's really going on with the patient. If they do have pain, how long have you had it? When did it start? How often does it occur? All right, progression of symptoms. So as the lesion gets bigger and coronary arteries get narrow, patient may have more pain with less exertion. Maybe I was able to walk a mile and now I can only walk a half a mile. Maybe I was able to shovel the driveway and I can only shovel half the driveway. One of the things my father said is he used to work outside with his flowers, and he said, I had to sit outside, like, and I'd have to stop and rest. And I was like, ooh, okay. So really getting those little subtle stories that they tell you that, you know, he used to be able to cut the grass, do all the flowers, weed whack, do all that. And he was telling me that he was stopping 3 and 4 times during this process, which he never did before. So really asking those questions of, talk to me about what this normally looks like. And he goes, and I just noticed I was like short of breath. So his big symptom was, remember he's diabetic, was short of breath, short of breath, short of breath. Okay. Patients may get dysrhythmias, ischemic events. So when we're talking about ischemic events, we're going to see changes in the ST segment of your EKG monitoring. Changes in the ST segment of your EKG monitoring. Remember, ischemic is reversible. Infarction is not. Now, again, sudden cardiac death, and I'll never forget this either. I worked with a nurse whose boyfriend, I think, was 29, and he was on the bike at the gym and just went over and died. Just died. Not overweight, very healthy, ate healthy, exercised all the time, just sudden cardiac death. So you definitely can't predict these things. You know, some patients can like see and feel things coming on, and sometimes it just happens suddenly and that's it. Gerontologic, so I want you to think about them, that their pain may be different. They might have silent coronary artery disease. So they don't have that character, like my dad, no chest pain, no nausea, none of that. Teach older patients to recognize their chest pain like symptoms. Maybe they're like my dad, short of breath and had to sit down. So even though he didn't have chest pain, he knew something wasn't right. Okay. Pharmacologic stress testing. So we can, and I don't know if you had the opportunity or if we've ever talked about stress testing, but I've had a stress test where you've had to walk on the treadmill. As we get older, we can't do that. We'll do a pharmacologic stress test. We can give medications to stress that heart and they don't have to walk on a treadmill. That's what that is. Cardiac catheterization. We're going to take a look at a couple things with cardiac catheterization. They're going to look at the coronary arteries to see if they're blocked. They're going to be able to take a look at what the ejection fraction is and how well that ventricle is contracting. And if you have an interventionalist doing the catheterization, he can go in and put stents in, he can plasty with the balloon. So not every cardiologist is an interventionalist. Interventionalist is someone who can intervene while doing the cardiac catheterization. And then definitely medications should be used cautiously. They can react a lot more dramatically, let's say, than a younger person with medications, so be very careful. All right. So get a history. What's going on? How have you been feeling? What have you, what has been happening? What were you walking, sitting, resting? What kind of pain assessment? Vital signs. Anybody know what are we looking for with the heart rhythm? Tell me what we're looking for the heart rhythm.
You want like the normal sinus rhythm? Like that's what you would ultimately.
Okay, so fair. You're saying that if we put them on a monitor, we'd like to see them as normal sinus rhythm. So we're looking for regularity, right? Is it regular or is it irregular? Okay, that's fair. And we can tell that even by just doing a peripheral pulse. What about the heart sounds? What are we looking for?
S1, S2.
Well, those are your normal ones, but if we're talking about abnormal heart sound, you're right. S1 and S2, you're absolutely.
So you're
Say it again.
3 and 4.
S3
S3 and S4. Yep. So when we're talking about S3 and S4, now we're bringing in a component of possibly some heart failure. S3. S4 can be heart failure as well, but sometimes with hypertensive patients, because the ventricle's so rigid and against that resistance, you'll hear an S4 with some severely hypertensive patients as well. Peripheral pulses, maybe they're bounding, maybe they're not at all because my cardiac output is dropped because I'm not getting blood flow and I'm not getting cardiac output. And my temperature of my skin could be cold because I'm not perfusing. Go back to those 6 Ps again, you guys. Okay. Psychosocial assessment. I see a lot of denial, like people will wait to come in. They're like, nah, this really isn't chest pain. You know, I just have indigestion. And they don't want to really believe that they potentially could be having a heart attack. And then the fear or anxiety could be like, what's to come? Do I have to have open heart surgery? Am I going to have the significant coronary artery disease? So a lot of psychosocial support is going to be important during this time as well. So I spent a lot of time, I think, talking about this already. So you can take a look at this, but you see how women are just atypical. Okay. And then it could be that they don't have any chest heaviness. You know, it could be maybe shortness of breath or palpitations or some numbness. Very different than that mid-sternal chest pain that, you know, men will complain of. Now, don't come to me and say next week you had a woman that came in with a heart attack and had mid-sternal chest pain, because they can have it. A lot of, they're just saying sometimes women are atypical compared to men. Everybody's different. It's a human element, so everybody's different. All right, so let's talk about what we would do. So if somebody came in with chest pain to the hospital, one of the first things that we would do is put them on a monitor. So let's just start with that. If I'm in an emergency and I'm having some chest pain, they're going to take me in the back and they're going to put me on a monitor. And then they're going to bring in the 12-lead EKG machine, because that is the best way to identify if there's ischemia or infarction, something going on with the heart. The 12-lead, you will never have to interpret a 12-lead EKG. That's a cardiologist's job. We interpret the rhythm strips. What do we see on that rhythm strip? Is it sinus rhythm, sinus tach? But the 12-lead EKG is the cardiologist's job. You're going to get it. You're going to put the patient on it, get them hooked up, and you're going to send that 12-lead EKG off to be interpreted by the cardiologist. A Holter monitor, more so outpatient. Somebody may be having some arrhythmias or something going along the lines, complaining of chest palpitations. That Holter monitor they may wear for a week, a month. It just depends on what the cardiologist orders. So that's something that they can look at to see if you're doing funny stuff when you're sleeping or during the day. And the patient documents how they feel at that time. So they take a little diary as well. The echocardiogram, that one above there, is 2D echo. Beautiful test. Everybody gets one. And I love the echo because it's non-invasive. And it tells me a couple things. It tells me how well the valves are functioning, opening and closing, because if they're not functioning, there I'm going to go into heart failure. And it gives me an ejection fraction. So it gives me an ejection fraction. It tells me how well that left ventricle is functioning. And that's really what I want to know. However, sometimes the 2D echo doesn't give us clear enough pictures due to body habitus or whatever, that we have to do the TEE, and that goes down the esophagus. So that is invasive. They do have to be NPO. They are going to have a scope down their throat, and they're going to be in like twilight. And the cardiologist has to perform the TEE, not the tech. The tech does the echo. So the TEE is a little bit more invasive, and it gives us a picture from behind the heart, because now we're down in the esophagus. And that's a great to tell me, again, what do my valves look like? What kind of ejection fraction does this patient have? Great test. Anybody that we're suspecting heart failure, probably going to do a 2D echo because it's non-invasive. And then we may do further tests along the lines. I ordered, I think, 4 2D echoes this weekend on the patients that I admitted this weekend. So it's very, very common test. You should really look at those, because that's going to tell you how well the valves are functioning. And that's how you'll pick up those murmurs, because you have mitral regurg or tricuspid stenosis or whatever. It's going to tell you how those valves look in your ejection fraction. Very important test. Stress test. You can have an exercise, if I'm able to walk on a treadmill, or non-exercise, and in parentheses, by non-exercise, you can put pharmacologic. We're going to give medication to stress that heart out. And that's that dobutamine below is with the one I see more often than anything. Or Dobutrex is the other name. Dobutamine will make that heart rate go fast. And that's what we want to do is we want to tax the heart. And if I can't walk and make somebody exercise and do it, we're going to do it pharmacologically. So it's really looking at if, as I'm stressing the heart with exercise or through medication, am I seeing changes of ischemia or changes in my rhythm on my heart? And is the stress causing me to become ischemic and have all these other changes? So the cardiologist can watch as you're stressing the heart to see if this is a significant problem. Then we take images afterwards, nuclear images, to take a look at the heart as well. There's your thallium scan below. Now, when I had my first stress test, because I had T-wave inversion, and I was good friends with a cardiologist. He goes, "Oh no, you're getting a stress test." I didn't have any chest pain or anything like that. It was just due to my EKG changes. And he wasn't quite convinced with the stress test, so he sent me for an MRI of the coronaries. And what I want to say about this fabulous test is they will give you a beta blocker, metoprolol, to slow your heart rate down. And in the MRI, they're looking for calcifications in your coronary arteries. And mine came back clean. I had no calcification, so he was satisfied. But the MRI, if they can't take the beta blocker, they're probably not going to have an MRI of the coronary arteries. You could do a CAT scan. I haven't seen it that often. Most frequently, stress test. And then if that looks ugly, then we're going to go for a heart cath.
Lorraine,
Yes.
so when they give Definity, what are they looking for? Like, what does that do?
With the echo?
Yeah.
Are they doing the bubble? Are you talking about the bubble test? Because I don't know the Definity that well. So I don't know. There's a bubble test that they'll do during the echo, and they'll just take a look at how the flow is through the heart. But I really don't know that answer.
Okay. Because on my floor, like, they do a lot of echoes, but then like they always ask for a nurse to push Definity, but I never know like what's
That I'm thinking is for the bubble test, and they look at the bubble like going through the heart during the echo. That'd be an Annette question, to be honest.
Okay.
Yeah, because she worked cardiac forever and a day. All right, top picture. So you remember this PR interval, right? This little bump here. QRS, correct? ST segment. So this is your T wave. So when we're looking at this, it should be isoelectric. I don't know if she used that language or not, but it should be straight. There should be no elevation off the baseline. They should all sort of line up if I put a piece of paper there. When we look here, do you see how this ST segment goes down? It's depressed. That's ischemia, meaning lack of blood flow. ST elevation here, and I always call these fireman's hats. Some people call them tombstones. I don't know if they look like tombstones to me, but I call them fireman's hats. ST segment elevation means injury. Now we're really in a lot of trouble when we need to intervene really, really quickly. We haven't, infarcted yet. At the time of ischemia and injury is when we want to intervene rapidly. We want to send them to cath lab and open that vessel up, okay? This is time where we can fix it before we have chronic changes with the ischemia or the infarction. All right, so one of the things, if we see that on 12 lead, and again, you're never going to diagnose the 12 lead, you have to recognize the fireman's hats or the ST depression, and you got to notify the physician, but you're never going to be able to, no, yes, you can. You can interpret if you take classes, but the cardiologist's responsibility is to interpret what that 12 lead looks like, okay? Your job is to get it and get it to him quickly. Cardiac catheterization. Couple things. They're going to find blockages in the coronary arteries, and they're going to look at the valves. Okay, so if I need valve surgery or something along those lines. Cardiac catheterization is invasive. So I want you to think about this. Need a permit, You need to be NPO, at least 8 hours. And probably gonna hold some anticoagulant medication, right? Because I'm accessing my groin or my wrist to get in there and to get up into the heart and to take a look at it. So very important that you make them NPO, informed consent. Take a look at your anticoagulants and have a conversation with the cardiologist. Okay. Electrophysiology studies, or the EP doctors come in and they are identifying arrhythmias. So if I have AFib or VFib or VTAC, they really focus on how to get that rhythm back into a sinus rhythm. So they may do an ablation where they'll actually figure out where the arrhythmia is coming from, and they will burn that area so it doesn't stimulate from that area. That ablation is it kind of wipes out that area so it doesn't allow that area to cause that arrhythmia. Again, electrophysiologists do that. Laboratory tests, a troponin, great indicator that I am infarcting. That's probably one of the first things that we'll get in the emergency room is a troponin level. Definitely more specific than a plain old CK level. Total CK levels can be elevated, but they can be elevated in muscle damage as well. Maybe I fell down the steps or whatever. Troponin, a little bit more specific. And then we want a lipid profile, of course, because now we got to start all those medications if that's out of control as well.
Lorraine, I have a question. I've noticed that the last 2 times we've been on the clinical floors, I guess they've gone to just doing that different troponin, like that high density troponin or something.
Troponin I, does that sound right? No?
Troponin high sensitivity, I think.
Yeah, the high sensitivity
okay.
troponin.
Oh, so that's definitely something new. Okay, last one I saw was just the troponin I.
Yeah, they said that that's like all the levels they're getting now. So when we're looking for troponins, we're seeing this different type of lab value now, and even the nurses on the floor have to look it up.
Yeah, because I'm telling you, I was just on call this past weekend and I got a troponin, well, it was a renal patient. Now that's interesting, Heather, because the troponin can be elevated in renal failure as well. So I'm certain that's why they're picking the high sensitivity one now. So they must have just transitioned to that. Boards probably won't ask you about that one, you guys, because boards is usually a couple years behind of what the new trends are. However, are you guys on like PCC? Is that where you're at?
Yes.
Yeah.
Yes.
Yeah. So that's a cardiac floor. So that's why you're seeing that. So that's exactly why you're seeing that. I can't imagine seeing it on boards just yet because that's probably a new thing nationally. And I'll have to ask Annette that question. And 2, maybe it's a Bon Secours Mercy Health thing and it's not a national thing. Make sense? I'm gonna have to look that one up because I didn't order you called it a high sensitivity.
High density troponin, is that it?
High sensitivity.
High sensitivity.
Okay, I'm gonna write that one down because I didn't get that on any of my patients this weekend. That's good to know. Thank you.
Lorraine, I have one quick question for you. Just
Yes.
back on the injury and the ischemia. Your ST segments is always going to be depressed with the ischemic. It will always be depressed.
Oh my God, are you a black and white person or what? For the most part, yes. Ischemia, okay. You'll see depression.
Okay.
Now you tell me that, and then you'll go and you'll find somebody that didn't. But most of the time when we see it, and it's really interesting, like when you watch this sort of evolve, you start noticing the depression, you're like, and then it flips to this injury. And now you know that you've progressed further along down the line. So you kind of see that nice progression. It's not really a good progression because they're getting worse.
Right.
But you will see that. So I've always learned it that way. ST depression, think ischemia.
Okay.
Yep.
All right. Thanks.
You're welcome. Oh. All right. These are your collaborative patient problems. These are your collaborative patient problems. So what are we going to look for? We're going to look, of course, for acute pain. Decreased myocardial tissue perfusion, and that goes with Brianna's question. Is this ischemia or is this injury? Decreased functional ability. Can these patients get around, do anything? Are they limited in their ADLs? Decreased ability to cope. You know, if you're realizing, oh, I've had this big MI and I'm not going to be able to work my whatever 18-hour job driving truck, very stressful. Potential for dysrhythmias. I want you to think about this. Anytime the heart lacks oxygen, anytime due to ischemia, you have a potential for dysrhythmias. If I become hypoxic because of my COPD, you have a potential to have dysrhythmias. The heart does not like when it does not have oxygen. So make sure that you're monitoring those patients' pulse ox, getting them supplemental O2, and we'll talk about how we do that in a minute. And then potential for heart failure, because if I have a heart that's infarcting or injured or ischemic, and it's not pumping effectively, things will back up and they'll end up with heart failure. All right, so now that we've talked a little bit, and now remember, I promise you next semester, she will take you from that injury. Oh my God, ischemia. I couldn't think of the first word. Ischemia, injury, and then infarction. She'll take you through that process again. And then we'll get into what do we do for that patient that has an MI. Not every patient who goes for a cardiac cath is an active MI. It might be diagnostic. So don't think that the cardiac cath's only for somebody who's actively infarcting. Maybe they're going for surgery and they need to have cardiac clearance or whatever. So the cardiac catheterization is diagnostic as well, okay? All right, we'll talk a little bit about medications, then I'm going to stop and then we'll go over that case study. So we'll talk about the case study for the rest of the time, the hypertension. But I want to talk just a little bit about the medications that would help with that oxygen supply and demand. So we had talked about that imbalance between supply and demand, patients having chest pain. Nitroglycerin.
Dr. Comer, can I ask a quick question?
Yeah, go ahead. Go ahead.
You won't be getting through the rest of this power.
No, I have next week to do that.
Okay.
Why? This isn't on your test.
No, I was just asking.
No, I mean, I have what? 4 more pages. I'll have plenty of time after the test next week to get done. I only have like 10 more, 15 more slides, 20 more slides. Yeah. What, are you worried?
Oh, that's me on a normal day.
All right. Well, give me a couple more minutes. I'm going to talk for 5 more minutes and then we'll have like 15 slides left. It's all good. It's all good.
Okay. All right. I'm going to calm down. Thank you.
Okay, good. Because I want to talk about hypertension and help review for the test. All right. So nitroglycerin decreases myocardial consumption through vasodilatation. And the key to the nitroglycerin is it dilates those coronary arteries. So it allows for more blood flow to get to those coronary arteries. You want that nitroglycerin. Morphine, beautiful drug, helps with pain. But in the case of cardiac issues, it also decreases venous return. So I'm not dumping a bunch of blood back into the heart and having this heart that's having trouble have to deal with more volume. It helps with pain and it decreases venous return. It vasodilates on the venous side. Vasodilates on the venous side. Oxygen, again, that should be one of the first things that you pop on your patient because remember, the hypoxia and the lack of oxygen to the tissues causes the dysrhythmias, causes the issues. Don't lay your patient flat, put them in a semi-Fowler's position and really, really, really try to keep them calm. Like don't walk in and go, oh my God, I think you're having a heart attack, because then you're going to cause them anxiety. So just say, you know, we got this. This is good. I'm going to put some oxygen on you. I'm going to give you some medication to help with that chest pain and really keep it a calm, quiet environment. Believe it or not, when I worked in the ICU, I could be calm and quiet when need be. So it's really important to try to keep everything kind of chill for them. So oxygen, minute they come in, that's one of the first things that we do in the ERs, pop them on some oxygen. Increase it delivered to the myocardium to decrease the pain, because the more oxygen the heart gets, the better and happier the heart is. You want to take a look at their breathing. You want to see if they're tachycardic. Are they hypoxic in blue? Not good. Bump up that oxygen. You're going to put them on a pulse ox and you're going to reassess their pain level. So one of the very first things you're going to do is you're going to pop them on oxygen. Nitroglycerin. We'll spend some time on this and then we'll pause after nitroglycerin. But patients learn to take it for their stable angina at home. They'll carry their little nitroglycerin vials with them. It dilates peripheral arteries. So remember, it's going to drop my blood pressure. So if I'm having chest pain and I take a nitro, shouldn't I sit down or lay down? So don't have them walking around and doing all kinds of stuff. Tell them to sit down, lay down, because it's going to probably drop their blood pressure a little bit as well. Okay, it's going to decrease the workload of the heart. It's going to decrease that demand. So we're going to have an increase in supply and it's going to dilate those coronary arteries beautifully. Okay, and it helps recruit collateral circulation around that area where that may be lacking oxygen. So remember, as we age, we have that beautiful collateral circulation that helps sort of that artery that's in trouble. Okay. So nitro comes in many, many, many forms. Patients at home take that little brown vial over here. A couple things I want to talk about with that when you're educating your patient. Sublingual, got to be in a dark vial. It can't be in a clear vial. It has to be protected from light. So you'll see that they'll be in a dark vial. They can't be older than 6 months. They're not going to be effective. So you got to make sure that they pay attention to how old that is. They can take it prophylactically. Like I know I'm going on my bike ride with my wife. I pop a nitro to help dilate my coronary arteries because I'm going to increase that demand, or I'm having an acute anginal event. Again, tell your patient to sit or lie down during the acute anginal event. Tell them not to move around, okay, because you're using up more energy and oxygen. We can do patches or cream. So over here to the right, this is called NitroBid. It looks like a toothpaste bottle, and then you measure out like the doctor will order, give 1 inch of nitro paste or NitroBid, whatever you want to call it. And you can see that that's measured out to 2 inches or 3 inches. And you have to actually measure it out on that little piece of paper and then tape that piece of paper to that patient. Here's the problem. People forget to take off the other one. So I've had patients come down to me with like 3 or 4 of those on. You must remove the old before you put the new. You must remove the old before you put the new. Same thing with the NitroDur down here, this little patch right here. You must document that you took off the old before you put on the new. I had a patient who had like 3 of these on. You must investigate that body and find where that old NitroDur patch is. You're going to write on this patch date, time, and initial so that I know that it's not 6 weeks old sitting on the patient. Oral, you might hear of IMDUR, IMDUR. We can take it orally. And then intravenous, this is for acute coronary syndrome. Somebody actively having an MI, it's right here. This is called Tridil, T-R-I-D-I-L. Tridil, T-R-I-D-I-L. And if I'm giving it IV, that's pretty serious, okay? The problem with nitro, let me see if it's on the next slide. Couple things. They develop a tolerance. So what they'll do is they'll say, take off that nitro patch from 10 p.m. to 6 a.m. So you see that allow for 6 to 8 hours without nitroglycerin, so they don't get tolerant to it. So that's your remove time. So take it off at bedtime and put a new one on the next day. When applying, use gloves, because I'm going to tell you right now, if you touch it, you're going to vasodilate, you're going to get a wicked headache, okay? The other thing, especially with the IV nitroglycerin, these patients will get a wicked headache. Now, they're actively having chest pain. You're not going to stop this medication for the headache. You're going to medicate the patient for the headache, Okay, so a lot of times physicians will give you a PRN order for that headache. Not every patient gets a headache, but sometimes it can be pretty significant. So you want to pay attention to that and medicate appropriately. Reach out to the provider if they've not given you any analgesic for the headache. And then during the hospital administration, document on the MAR application and removal. So you'll see a start time and a removal time. You need to make sure that you're documenting both, because you don't want them to come with 3 patches attached to them. Sublingual, I already told you this, lie down. Oh my God, never chew. It has to dissolve underneath the tongue. Never chew. They are going to feel some tingling. That's normal. May repeat 1 tablet every 5 minutes times 3. This is standard. I think this is even in basic life support. Over 15 minutes. So the first 5 minutes. They recommend that after that first nitro, if you're still having chest pain, call 911. Take your second nitro, but already get on the phone and call 911 because the first nitro didn't work. You can take up to 3. You can't just keep popping nitro until somebody shows up. So the max that the patient can take is 3 tablets. But if they have pain after that first nitro tablet, that very first nitro tablet, they need to call 911 because the nitro didn't take care of the pain. So there's your prophylactic nitrate 10 minutes before beginning an activity. Anticipate hypotension, tachycardia, and headache. They're going to drop their pressure. It vasodilates, okay? And when my pressure drops, my heart rate goes up to compensate. So that's why you don't want them moving. You want them to lay down. You don't want them doing any type of activity because the pressure is going to go down, especially if I've taken 3, and the heart rate's going to go up, okay? And then they're going to get a headache. Note number of anginal attacks. So they should keep a diary and they should talk about when they've had chest pain episodes and what was happening before and after. Absolutely, somebody with their angina should always carry a bottle with them, always. So educate your patient. They should always have it because you can't go, oh, I need to get my nitro. I got to drive home 15 minutes from here. Should always be with them. They should always have a medic alert bracelet and keep in the original container. Remember, dark brown, it's got to be protected from light, avoid exposure to light and moisture, and then discard after 6 months. I've already talked about that. I'm going to stop here and talk about your case study. Questions before I move on to that? Are you all sleeping?
No.
No, I'm awake.
No, I heard one.
Still with you.
I am awake.
Okay, good. Good. All right, so let's talk about this case study and let's sort of review hypertension for the exam, right?
Yes.
Okay, so Mike Kelly, if you look, it's this little guy. Let me show you. Is this looking familiar? Did you do him?
Yes.
Okay, good. So big concept of here is perfusion. And haven't we talked about perfusion from the beginning? So we're going to talk about what we need to recognize, what's relevant in his assessment. So Mike Kelly, 51, 6 feet tall, 275 pounds. BMI 37.3 with an abnormal distribution of weight around his abdomen. Oh, sound like metabolic syndrome? Yes.
Yes.
He does not regularly exercise, does not like to cook, and eats fast food 3 times a week. Okay. He has smoked 1 pack per day since the age of 20 and has a history of hyperlipidemia. Boy, he's a hot mess, isn't he? Hyperlipidemia. Unable to afford his medication and has not taken since he was diagnosed 5 years ago. Ooh, we got a lot to work with here, don't we? No current medical diagnosis. Concern came to ER because he's easily fatigued, has a headache past 3 days, and has not improved. So he's self-employed, owns his own business, no health insurance, father has hypertension, and died of an MI, okay? His wife she came with him. He's stoic about his health problems, but must really bother him or he's afraid. He took Excedrin and Motrin, oh boy, for pain and it didn't help. So I want you to tell me what's relevant from his present problem. What are things that like kind of came out to you like, oh my God, this is alarming.
His weight and BMI.
Okay, so the BMI 37.3, correct? Right? And that
Mhm.
abnormal distribution of weight around his abdomen. Okay, good. What else?
His
The smoking.
So we got smoking 1 pack a day. Who else said something? Go ahead.
hyperlipidemia, yeah.
The high cholesterol, the lipid levels. Okay, keep going.
His
Eats fast
diet.
Eats fast food 3 to 5 times a week. I'm sorry if I cut someone off.
That's okay. No, I'm loving this. Eats fast food. And what does Lorraine hate to do?
Exercise.
exercise.
All right. So fair enough, right? So now, God, he's got a lot of things that we got to teach him, doesn't he?
He's non-compliant with meds.
Ah,
Yeah, that's one thing that's really worrying for 5 years.
right. Okay. So now what the heck? Where do we start? Right. Okay.
And it might be financial too.
Definitely. We got, and that's where I would be bing, social service. Okay. So now give me relevant data from his social history.
Father had hypertension and died of an MI.
Yep. What else?
No insurance.
Okay. What else?
Motrin, Excedrin.
There you go. He took over the counter meds, didn't he? Right. All right. So patient care begins. Tell me, all right. So do you have that? I don't know if yours shows the same as mine. I should have probably pulled that up. Let me see. Let me see. I want to pull up what yours looks like versus mine.
There's not a face on ours.
I know. And I pulled up the one that, here we go. Unfold. There. Does that look familiar?
I don't see your screen.
Let me share it. Hang on. Hang on. Hang on. Desktop. Share. I got it. You see it? Okay, got it. All right. So we just did this part. Now, why isn't this moving? There we go. Oh my God, I'm working with the Mac, you guys. It's opposite of God bless it, America. So what do you think about his vitals? Anything about his vitals?
Blood pressure.
Yeah, that BP.
You're not happy with that?
No.
Wouldn't that be like a hypertensive emergency?
So where would we probably maybe put him?
ICU.
Yeah, maybe, right? Right? Now, maybe he's an ER and we get it under control, get a bit lower, but do we want to drop this blood pressure down to 100/60 now?
No.
No,
No.
you could have rebound hypertension.
Okay, so we want to take our time. So now,
I would also watch his O2 sats are starting at 95. So I know he's a former smoker, but I would probably watch and make sure that doesn't continue to drop.
That's fair too. Definitely with this prior history. I'm not against that, especially if he's got this pain 8 out of 10. Is he hyperventilating? I think that's a great idea to take a look at that. Heart rate looks fine for right now and it's regular, but it's definitely something, that I would probably watch too, because we're about 88. And if we start adding medications, could that change?
Yes.
All right. So vital sign data, which are relevant. So you guys said the blood pressure. Talk to me about this.
Bounding pulses.
Okay, so you said bounding pulses as well. But let's just talk about what that high blood pressure, what does that look like physiologically? Like, what are you worried about? What are those concepts that I talked about?
It's his
It's your-
cardiac output versus his stroke volume, venous return. So he's having problems, and he could possibly, that could give him a stroke or MI.
Okay, that's fair. You could
his heart's working too hard right now.
Increased workload. And what were those two concepts that I talked about that happened before and after in the heart?
Preload and afterload.
Preload and afterload.
Yes, right? So if you looked at his blood pressure, let's look at his blood pressure. That's high afterload, isn't it?
Mhm.
Now that heart has to work damn hard to get that blood out, doesn't it? So the afterload is increased in him, and it's really making that heart work a lot harder. Okay, so you want to think about that, because what could he go into then? If I can't get the blood out and it goes backwards, what can I go into?
Heart failure.
Hands down, in which I'm going to talk about next week. So now I can go into heart failure, because now I can't get the blood out because my afterload is high. Everybody with me? And it could back up and I can go to heart failure. So we're definitely concerned about that. What other organ can be damaged? So let's talk about that end organ damage. So we can have cardiac issues. Give me some others.
Kidney, renal.
Okay, so let's talk about kidney. That's exactly right. Now I got this high blood pressure and it's constantly beating my kidney. Can it damage my kidneys?
Yes.
Didn't I tell you it's one of the #1 causes of kidney failure is hypertension? Okay, good. What else? So you told me heart, kidneys,
The brain.
Eyes.
so eyes, so we can have that retinopathy, and whoever just said brain, yeah, we could stroke, right? We could have a CVA, right? Definitely. So do you see, even though the guy's young and you think, well, all right, it's not so bad, whatever, this could end in a very bad way, could it not?
Absolutely.
Yes. Okay, so I love it that you guys are thinking of all those things. So you talked to me about the kidneys, you talked to me about stroke, you talked to me about all those wonderful complications that go along with hypertension. Hypertension, if that's all you got, it's fine. It's the end organ damage that I'm worried about. Okay. Now, what about this headache?
Isn't that from the elevated blood pressure?
Okay, keep going. Yep, keep going.
We want to look for changes in the headache, though.
Give me, okay, talk to me.
Is he having any changes in his vision with the headache?
Definitely all of those things, right? And I think it was Audra maybe said about a CVA. So, do we have increased cranial pressure, and are we bleeding in the brain or something because of that high pressure? So you got to pay attention to that. All right. You guys are doing great. Okay. Ooh. Okay. So general appearance, he appears uncomfortable. Well, hello, his pain's an 8 out of 10, isn't it? Breath sounds clear. Very important to pay attention to that right now. Non-labored. So right now, lung-wise, he sounds okay, right? Clear, he's not labored. Pink, warm, dry, those 6 P's sound good. Bounding pulses totally makes sense with the high blood pressure, doesn't it? Totally makes sense. Equal palpitation, all of them are equal, so that's good. Alert and oriented, I like that. Abdomen soft, voiding without difficulty, urine clear, yellow. Skin intact, skin trigger elastic with no tending. Sounds pretty good, doesn't it? Assessment-wise, okay? So tell me what is relevant out of that assessment.
Bounding pulse.
There you go. Bounding pulses, right? So pulses,
Yeah.
bounding.
I put the notes and everything, but I'm gonna go lay down. Can you put them away or wake me up around 9?
Yeah.
Thank
When
you.
you put them away, what do you do?
I can't hear.
Sorry.
You know what? It's her cat. Her cat lays on her computer.
Oh,
and unmutes.
my God.
I'll call her and tell her.
I was like, I can't hear what she said. All right. So
I'm
the
sorry.
bounding, no, you're fine. The bounding pulses, there is a significant hypertensive crisis. Not unusual to have really relatively normal assessment. And didn't we say that? Most of these hypertensive patients are asymptomatic, right? The morning headache. Nothing really else. So I could walk around Walmart and be hypertensive for years, correct? So pretty much his assessment's negative except for the bounding pulses. Okay. Let's see. Let's move on. Diagnostics. Oh, look at that creatinine. And look at his glucose. Oh, look at his BNP. Oh, and LDL and HDL and total cholesterol and triglycerides. Oh my God. This is everything we just talked about today. He does not have blood work like Lorraine does. He does not have blood work like Lorraine does. So what's your brain saying right now?
Cholesterol.
So we got well, a couple things. Let's break this down. So his electrolyte looks fine. So the K and the sodium are okay. I'm not losing sleep over that. That glucose is elevated, isn't it? So we're not really under control there. Okay. And our creatinine is elevated. What the heck's going on? So has he been hypertensive for a while? Because now we're starting to show end organ
Failure.
Yep. See that? Do you see that? Now the guy's minding his own business in his business, working on autos, doesn't even know this. So this is what I'm trying to say is patients don't know this. Now your white blood cell count's fine. Hemoglobin could be, I mean, he's a guy, but it could be, he might be a little dry. I don't know. Platelet count, fine. Look at the BNP, up or down?
Increase.
Up.
Oh, could we be possibly in a little bit of heart failure? And then that lipid panel looks terrible, doesn't it?
Yeah.
So
But he
what
also
is
hasn't been taking his meds though.
excellent. Whoever just said that. So what's our first active priority for him with that regarding those meds?
Starting the meds.
Starting the meds,
Okay, all right. So do you see why, like you go, hey, and normally if I walk in with something and go, I just looked at your labs and they're like, not good. Like, talk to me about, and I think somebody brought up, could it be an issue of financial? Yes. Some of these meds are extremely expensive. Let's get social service on board to get them the help that they need. Okay. All right. So let's look. Let's see if I missed anything on that. Nope. All right. Let's keep going. Oh, look at his chest x-ray. What did I tell you about that? Look at his chest x-ray.
Moderate to severe cardiomegaly.
Why? You people are so smart. I can't stand it. So yes,
It's all those cheeseburgers.
that and he's been hypertensive. And remember that your heart, it's a muscle. So the more I'm beating against it, the bigger it gets. Everybody got that? You're building that muscle. So that cardiomegaly is due to that chronic hypertension. So this guy's been uncontrolled for a while. Wouldn't you agree? This just didn't happen overnight. Okay.
So
good.
Lorraine, is his heart becoming stretched? Is that what you're saying? It's becoming stretched
I
out?
wouldn't call it stretched.
Okay.
When you
Thick?
think of the concept of stretch, Brianna, it's more of like volume,
Okay.
like somebody in heart failure or fluid volume excess.
Okay.
With cardiomegaly, it's like lifting weights and lifting weights and lifting weights and lifting weights, that muscle becomes bigger. So
Okay.
your heart becomes bigger.
Bigger. Okay. Gotcha.
Yep. All right. So let me see what the next, put it all together. Interpreting relevant clinical data. What is the primary problem?
Hypertensive.
It says, now this is what Keith RN says, hypertensive urgency that may be a hypertensive crisis. Okay. Primary hypertension is associated with, what has he got that's causing his primary hypertension?
Hyperlipidemia.
And obesity and smoking.
Smoking.
Does he smoke?
Activity.
Yep.
Yeah, he smokes.
High sodium diet, right? All of those risk factors. So what are we doing down here? Why do we do the BMP? Why are you doing that?
We need a baseline.
Yeah.
Okay, I like it. I like that. I like a baseline. And then what in particular?
The creatinine.
Yes. Yes, we really want to know what that creatinine's doing because it's already elevated. He's showing up with it already elevated. So if we don't get that blood pressure under control, it's going to get worse. Okay, that creatinine is going to get worse. His kidney function is going to get worse. Tell me about the CBC.
Any infection or shock?
Yeah. Bleeding, anything like that.
So definitely, right. Oh, that's a good point. Like, let's say that we don't treat this blood pressure and he bleeds into his brain. So my hemoglobin could drop, couldn't it?
Mhm.
Yep.
Very good. Very good. What about that BNP?
Heart failure.
Definitely. Remember, and this is Brianna, where you were kind of talking,
Okay.
when a patient's in heart failure, it's extra volume, then it's really stretched because I got way too much in my tank.
Okay.
Okay. So now when the ventricle gets really stretched from excess volume, BNP gets released to help the body diurese. So the more BNP released, the more I'm going into failure. So the higher the BNP, the worse heart failure it is. Okay.
So back to the heart that
Yes.
you were explaining, excuse me. So that would pretty much be like cardiac hypertrophy, correct?
So yes, because you're hypertrophying the muscle, but we don't usually refer to it, we just call it cardiomegaly, meaning that the heart's enlarged. But yes, to answer your question, because when we get into the different types of cardiomyopathies, Dawn, we're actually going to talk about those types of things. That's correct. All right, tell me about the lipid. What do you think?
Atherosclerosis.
You want to put them on some meds too? So we thinking over here that we're going to do some meds? Maybe eventually? Okay. What about the UA? Why do I care about a urinalysis? What are we looking for?
Albumin and glucose.
Yeah.
Hey, all
And
right.
and hematuria.
Oh my God, you guys are so smart. So we're looking at, are we spilling protein? Because now we know if I'm spilling protein that I probably damaged my kidneys from that stinking hypertension, right? And somebody said hematuria, I'm spilling blood. I shouldn't spill blood. And I think somebody said sugar.
Catecholamines too.
And catecholamines, yeah. And somebody said blood sugar, and that's really telling me their control of their blood sugar, because remember I said it spills over about 200. So definitely looking at, is he not a controlled diabetic? Because I got to get that under control as well. Okay. Oh my God, you guys are so smart. Okay, 12 lead.
Any dysrhythmias, infarcting.
ST elevation, ST depression. Are we ischemic? Are we anything like that? Excellent. Okay. I'll try to finish up in a minute or two. I'm sorry. Okay. Priority. Let's see. Collaborative nursing care. Let me find that part. Here we go. What is your priority? What are you going to do? What's the number one intervention you're going to do right now?
Lower his blood.
Got to get that BP down.
Well, you got to assess it first.
Oh, yeah.
So, okay. So very good. Think about it. And how often are you assessing my blood pressure?
Like every
30 minutes.
No,
30 minutes.
every
15 minutes.
15. Yep.
15.
Depending on what you're doing with the medications. I like it. Okay. What do you want to give me? What medication? Which one's
Beta
ordered?
blocker.
Yeah. Which one is it?
Labatol.
Labetalol. Labetalol. Yep. Remember I said I give that in the ICU IV push? I don't see labetalol given like by tablets much anymore. I give that push for blood pressure. So that's exactly right. What are you assessing in my beta blocker before you give me that damn beta blocker?
Blood pressure, heart rate.
Blood pressure. You, for God's sakes, don't give me the beta blocker if my heart rate's 40. Okay, good. What else you want to assess?
Hyperkalemia. Monitor for that while they're on it.
For the beta blocker? For
Oh, no, just kidding. Just kidding. Thinking for
You want to reassess their BP and their pain.
All right, wait. So go ahead, Heather.
Do you want to reassess their blood pressure, but also their pain and their heart rate? Because
so their headache and their pain and all that stuff. Okay, go ahead. Who else just said something? I missed it.
I did, but it was blood pressure.
Okay, definitely you guys, right? We're not walking away from this patient, not with a 220 over whatever the heck it is. We're going to assess for complications of hypertensive emergencies, heart failure, stroke, all those things that you guys just talked to me about. All right, last, let's see, care. Oh, I want to talk about meds. Let's tell me, so the labetalol is a beta blocker. I thought I saw Lasix. Did I make that up?
Yeah. I don't remember Lasix on
I've
this.
been making that up. Okay, let's just briefly talk about meds. So labetalol, and do you see this? It's 20 milligrams every 10 minutes. So do you see how frequently I can give that? That's why I said we normally do that in the ICU. And I want you to see what the goal of the BP is. It's not normal, is it?
No.
No.
Please remember that. You're not dropping them low, guys. They're going to tell you what the goal is. Your cardiologist or whoever's ordering these medications. Now, once we get him under control, and this labetalol is IV for the emergency, give me some medications that will help me get my blood pressure under control.
Metoprolol, extended release.
So you want to put me on, okay, and that's fair. I can go home on metoprolol or low pressor, okay.
You
And
give him
Diuretic.
a diuretic.
what kind of diuretic do you want to give me?
I would give him
Thiazide.
I first.
So you all have your, okay, so let's start. A lot of times you see thiazides first. That's exactly right. So what do you expect with giving a diuretic? What is the effect, the anticipated outcome?
Increased
Increased volume.
Right? Increased urine output or decreased volume in the patient. That's the expected findings. That's the expected outcome. Now, what are we worried about with the diuretics?
Hypochloremia.
With an electrolytes.
Okay, so what kind of electrolytes, Audra?
Okay.
Your potassium because you pee it out.
Okay, so your potassium because you pee it out.
Your sodium.
Definitely could lose some sodium, right? What else are you worried about with giving diuretics or any of these medications that?
too much fluid loss.
Absolutely. And
Decrease
what will
the
that?
blood pressure too much.
So will the smart nursing student give this patient their diuretic if their blood pressure is 80/40?
No.
No.
So do you
No.
see how you're evaluating and going, wait a minute, I'm not giving this med? Because some people go, well, it's ordered, I'm giving it. No, not a
So
smart nursing student.
Then this patient, would they be a candidate for like one of the accommodation drugs we talked about in tonight's lecture? Like
Why
that?
Why not? Because he's got two things going on, doesn't he? Why not? Why not?
Dr. Comer, can I ask you a question? So
Yes.
if, you know how they, sometimes they'll have parameters to give, you know, a PR and blood pressure medication. What if they fall very close to those, you know, just a few numbers?
So
very close. What is the like rule of thumb?
that's a really good question, Carly, because you know, you're damned if you do and you're damned if you don't. So then you go, all right, well, what do I do? Well, one of the things that I've done is I've looked back, maybe yesterday, and I say, well, what the heck went on with them? And did they ever give that med yesterday because of whatever? And then I see their response. So let's say you're talking about their daily diuretic and you're like right there at a systolic of 102. And you're like, well, I'm going to look at yesterday, what their pressure was before they got the diuretic and afterwards. So I'm evaluating how they did yesterday on that drug. That's my job as the nurse to figure out, or talk to whoever had the patient yesterday and say, hey, how'd she do with that diuretic? Oh, she's fine. Nothing happened, or her pressure stayed the same, or boy, she bottomed out. Then I'm going to make the phone call. Does that answer the question?
Yeah.
Really look at, I mean, there are times that I have conversations with 5 or 6 other people and go, what do you think? Should I give it? You know, and I'm nervous. And then I just kind of go back on their trends and they go, oh, they got 100 of whatever yesterday and she was fine. So then I know how she reacted the day before, that I'm a little bit more comfortable giving it. But I still met that criteria because he said 100 and it was 102.
But still monitoring, Lorraine, correct?
Oh my God, yes.
Okay.
Oh, I don't care when or what med. I don't care if she's had a high, I'd still go back and reevaluate. Any medication I'm giving that can alter the heart rate or the blood pressure, my butt's going back in and looking. I was lucky in the ICU because I had a monitor that told me what their heart rate was all the time. So I didn't have to physically go in and take an apical or whatever. But it's really a smart nurse that goes back and says, let me see how you did with this. Especially with that first dose. Remember we talked about that first dose, how sometimes people get up and crack their head on a table. So really paying attention to how do they respond? I don't know until you give me the med, if it's my first time taking the med. So, you know, you worry about those things. Always go back and evaluate. No one's ever going to slap you or yell at you for taking too many vitals. Maybe the patient might, but no one's ever going to say, well, you assess that patient too much. Does that make sense?
Yes.
Any other questions on meds? Because I know your class is done, but I want to just help review if I can. Silence. I will, and I guess I gave you guys the answers to all the case studies. Oops, my bad. Wasn't my intention. But then Kristen locked them back up on me. So if you weren't fast enough, you didn't get them. But I will release this so you guys have opportunity to take a look at it. But I think it does a nice job of really thinking about what you need to do and how you need to intervene. And it ties it together with the risk factors, what to look at in that assessment, those kind of things. I think it does a nice job of pulling it all together. I don't know if you guys agree or not, but I think
it actually helps kind of having it, to look at and make sure I was actually looking in the right direction. And, I think it was kind of helpful.
Good. Okay. And I'm glad that was my intention, is sort of pull all that information together and have you go, oh yeah, this all totally, and like, look how you guys were answering the questions already. Yins are smart. So like, you got this. So like, I really think that I'm not from Pennsylvania, but I like to say yins. I don't know why. But I think that you guys sort of have a grasp on this hypertension. I really do. I mean, you were able to answer these questions.
We had a good instructor.
Oh, she's awesome, isn't she?
I love her. I just love
my God. So
I like her.
She's all right. But the beauty of my cardiac meds and the list that I gave you, as we transition into heart failure, you guys, they're the same meds. They're just taking them for heart failure. They're the same beta blockers, calcium. They're the same. So if you get them now, you're going to get them throughout everything else that I'm talking about. I don't know if that helps.
Hallelujah.
Praise Jesus, right? All right. Any other questions I can answer?
Dr. Comer, I got one.
Yes.
You know how like the patient was put on the labetalol?
Mm-hmm.
And it says on our slide, like mild to moderate, heart failure in conjunction with like digoxin, diuretics, and ACE inhibitors. How come they want to put him on, you know what I mean? Like for this, like they didn't put him on and for it. Like I thought it'd be like with that. Like they did, the only medication they gave him was labetalol. Like they didn't put like digoxin.
We're not, okay, couple things. I'll tell you what. First of all, he's in a crisis right now. Let's get the pressure down. Digoxin takes days to get therapeutic. So if I give it IV, I got to give 4 doses when I'm loading up, and it takes a while. So that digoxin isn't going to miraculously, and he doesn't really need digoxin just yet. I really think, this is my assumption, if we get the blood pressure under control, he won't mimic those heart failure signs because he doesn't have such a high workload. Do you see what I'm saying? So let's get the pressure down because we're in an emergency crisis. Once we get that down, if he still reflects heart failure and all that stuff, then let's start adding. But right now, this is an emergent situation. Let's use that IV medication. And I think Elise said, well, we could put him on Toprol when he goes home. And that's exactly right. We're right now just trying to get him out of that crisis mode of him not having a stroke or retinopathy or something along those lines. It may be added, not at this point, but you're right. It may be added at some point.
So if we treat that crisis right then and there, Lorraine, then the BNP should come down. Is that what we're looking like, those monitored labs?
So here's what I see a lot of times. It's going to be symptom management. So for instance, and this is how I picked up heart failure in my patient I had this weekend. I listened to her lungs and she had crackles. She was not short of breath or any of that stuff. And the doctor I talked to said, oh yeah, we should get a BNP. I go, and she was in heart failure. No other symptom. And I heard a murmur, which she said she never had before, which was something new. But so I just drew a blank. What the hell did you ask me?
About the BNP and the labs.
Yes.
With the start.
Thank you. See, I'm going to get there, old brain. So we don't routinely do serial BNPs.
Okay.
Here's what we do. We do it one time and we say, oh my God, they're in heart failure. Then we do all these beautiful interventions, diuretics, inotropes to help that dig that you're talking about. And if my patient's looking better, there's no need for me to get a BNP again because we're really using it as diagnostic. Now, on the flip side, Bree, if that patient's getting more short of breath, holding on to more fluid, yeah, I'm going to get another one to see if it's going up. Do you see that? But normally we use it as, we diagnosed it. You have heart failure. We need a diurese.
Okay.
Yep.
Thank you.
Good question. Any other? I don't want to keep you long. I mean, I could talk all night, but I don't want to keep you forever.
Dr. Comer, we could sit here and listen to you talk forever.
No, you cannot.
Yeah,
You
no, you're
fat
just,
liar.
no, I'm not lying. You are the best. I mean, I could listen to you for all night long.
I have to tell you though, and I was at work and I took this new position and I'm like, why did I do that? Because I love this. Like, and I said, this is the happiest I have been lecturing you guys for the last 3 months.
It shows.
Oh yes, definitely.
I mean,
Definitely.
I'm in my pajamas, I'm not gonna lie. But I could not wait to get home because I worked all day at the office and then I came home here and I said to my husband, I shoveled down some dinner and I said, I can't wait to go lecture. This is what I love. This right here and being part of this whole process. I am so happy to be here. Like I said, I'll talk to you guys all night. I could do it because I don't.
There's no one that does it better. No one.
Oh, you're
no one that does it better.
And I just feel so bad because of everything that's going on for you guys. Cause I know like every single instructor I've had, like, cause it's been crazy for me, like at times has been so helpful and been there. And I know you guys care, but I know it's hard on everybody because they're like distracted because this is all going on. And it's like, what are you guys going to do now? Because this probably wasn't in your plan,
No, I was going to retire from this place. I was going to retire, and now I got to, who wants to hire a 55-year-old broad that can't figure out how to work a Mac?
You have initials that take up 2 spaces on a piece of paper.
Stop it.
Yes,
So what? So
Come
what?
on.
So no, I got plans. We're going to Hawaii with the CAD. I told you.
Go to Hawaii.
We're going to Hawaii. So, we have a job to do and I love this job and I will continue to be the person that I am. And I hope that reflects what I'm teaching, that I love being here. I love being part of this. I love your questions. I said, I can't wait to see you in the classroom. Like, I'm so excited to be.
So we will get you in the fall then, and we will get to be with you in person one more time.
I don't know how much you'll get me to be in the fall because I'm going to be running 110. So
Who will we have next?
So all of the critical care specialists, all of us that have critical care expertise. So Jill is going to take over as course lead. It's normally me, but since I took this position and then somebody's leaving, so I'm replacing that person in 110. So Jill will be in charge of the course. I'm not giving up my renal because I love me some renal. And so I said to her, can you let me teach the renal part? Because I taught shock, I taught antibiotics, like, just fun stuff. So I don't know what I'm teaching in your course, but I'm not letting her pull me out totally. So I said, too bad, I'm teaching. But normally Annette helps us too, because Annette is our cardiac expert, but she's busy with OB. So I don't know if she'll be like, she used to do the MI because she took care of 1,000 MI patients. That's why I tell you when I say ask about cardiac for MI, that's Annette. And then Deb Phillips does she does the cardiac component too. The cardiac component is quite large in 239, pulmonary edema, MI, cardiovascular surgery, which you go to the cardiovascular surgical unit.
Oh, nice. Yes.
So and the beauty of next semester is that you have the opportunity to learn about an open heart and then go see it.
Oh, cool.
So our cohorts up in Toledo, they don't go to ICUs. They don't go at all. And we're like, what? Because we send you to SIC, we send you to CVIC. We're like, what? So like when I talk about when Jill talks about neurotraumas, the car accidents and those kind of things, that's all I took care of in the spring was neurotraumas. So you see everything that we're teaching, which is so beautiful, like to follow that. And when I talk about renal failure and CVVHD, you're going to see it in the unit. So that's the beauty of next semester is you really can tie what you've learned in class to the clinical. So I love next semester. It's like the most fun. So
I'm so excited.
I'm,
Are we rotated between 3 and 4 then next semester? Like,
so, it'll probably be rotating between 3 units.
oh, okay.
Like a medical ICU, I don't know which one yet, CVI and SIC. Beautiful all experiences. I normally am a medical girl, but it was a COVID unit, so I got bumped out of there. So I went to SIC and oh my God, they were so awesome there. They were so awesome there. So I learned so much down there. I was like, well, I never worked trauma. You know, I'm a medical intensive person. I work with like 90-year-olds that have pneumonia and renal failure. So it was a big eye opener for me as well. And they were wonderful. I mean, just, it was a great experience. So, and
Now
they,
that's downtown, correct?
SIC, yes, because we're the trauma center. So yes, yes. Some people will go to Boardman ICU, which is the medical ICU, and some will go to St. Joe's. It just really depends. So, and both of them are pretty equally the same. And then we have CVIC and SIC as well. So it's just a overall, most students are scared shitless in the beginning because there's so much in the room, but by the end of the semester, they're all like, you know, we love this, you know what I mean?
Where is St. Joe's in location to
Warren.
Youngstown?
So it's in Warren. It's a cute, and I'll tell you what, I was on call my first weekend with the renal guys, and he goes, you have to go to St. Joe's. And I said, sir, I don't even know where St. Joe's is. And he said, well, we have a patient there. I go, but I don't know where St. Joe's is. He goes, Google it. And he left me. So I had to go St. Joe's. And they were so nice. I walk in and I'm like, I don't know where I'm at. Where's the ICU? I have to go to the ICU. And the lady goes, let me walk you over to the elevator. It's very, very, it's a great, and the nurses were so, I go, listen, I don't know what I'm doing. I don't know what I'm doing. So tell me where my patient is. I don't know where room 11 is. They walked me to the patient. They helped me with everything. They were a really great group. And Jill goes out to St. Joe's and she loves it. Loves it.
I put in a request to stay at Maine, just because it's so much further of a distance.
So everybody has the opportunity to come to Maine twice, CVIC and SIC.
Okay.
What the issue will be is whether you go to Boardman or St. Joe's. That's the outlier.
Oh, okay.
St. Joe's, yeah.
Okay.
So I'm working those details out. So that's the outlier right now.
I mean, would I be able to send you a private email asking?
You just announced it in front of all your people.
It
It all depends on what day I want St. Joe's. It all depends on what clinical day too, because like I know I have St. Joe's both days. Yes, I have St. Joe's both Friday and oh, you know, it's Saturday, people. You're going to St. Joe's and Boardman because I don't have CVIC, but I have.
So we do both. I'm sorry. So we'll go downtown and Boardman or Warren. Oh, okay.
Yeah. What happened was years ago when I first started teaching this, you'd go 5 different places. I would just ship you all kinds of places for every 2 weeks. And we sort of narrowed that down a little bit more just because of availability of units. So you go 3 places. And it's really kind of cool, I think, because one of the things that when and the Toledo people are always jealous. I'm like, oh, we had ECMO and an open heart. Like we brag about it all the time because they don't get to see that. The students observe in the ICU. No, we're giving meds every week. We're doing stuff every week. We're putting lines in, whatever. We're really engaged on that clinical. So, and we're lucky because they know us and they kind of let us do a little bit more.
Arlie, are you from PA?
Yeah, unfortunately, yes.
Well, I was going to say, St. Joe's is really not that far. If you go down 82, it's right off. I mean, it's right off.
I'm going to go stay at Dr. Colmer's.
What? I'm not doing clinical. It's not going to be me.
She's at your house.
Oh, and then I'm going to. I don't care if you're doing clinical or not. I'm just going to come stay at your place.
Well, you're going to have to share the bedroom with my mother-in-law.
That's okay. You know what? I love to talk to people. I could talk to her all night. It won't be a problem.